A very good morning to all, and welcome to day 2 of HEMENEXT. And I think without wasting much time, let's start the first session of the day. And for that, let me invite Dr. Sunil Bomber sir. Sunil Bomber sir to chair the session. And everybody knows Sunil sir. He is a senior faculty and a senior pediatrician with a keen interest in pediatric hemo. And I would request Sunil sir to please introduce the first speaker. So over to you, sir. Can we have a mic? Sir, please mic.
I'm not really strong. I'm delighted that you have invited me here. But anyway, I welcome all the delegates and especially Karen Mandu, who is a opening batsman. And I know Karen Mandu from Lily Harding. Okay, the new batsman. All of them are from Lily Harding, and I welcome Karen. He is general DM from the AIMS and having working as a professor in the Lily Harding Medical College. The talk is on the UACs, the blood figures in the pediatric practice.
Thank you, sir. Thank you, organizers. So, until recently, when we talk of pediatric thrombosis, it's mostly needles, parental anxiety, non-availability formulation. So, here I will start with. So, my talk will have a little background on the pediatric VT, classical anticoagulants, then coming to direct oral anticoagulants with a clinical case example of a 17-year-old male. So I'll start with the case. So 17-year-old male who was in induction phase day 12 presented with multiple episodes of GTCS without any fever, and the last chemo he received was on day 8, dexamethasone, vincristine, pegisparaginase, dono, rubicin, IT1 day 8. So this is what the ICBL protocol looks like when on day 8 he received these chemotherapy, which included pegisparaginase, and on day 12 he had seizures. So we controlled him on 3 anti-epileptic, supportive care, started on low molecular weight heparin. CSF on day 8 showed no malignant cells. His MRI brain showed superior sagittal sinus thrombosis visible in this, with, as seen here. This black, this is the thrombus. So during follow-up, we missed his second dose of pegisparaginase. There's no recurrence of seizures. He has completed induction. His marrow is in remission. Repeat brain imaging showed partially recanalized chronic thrombosis. We are continuing on low molecular heparin. And now we have started on consolidation, and pegisparaginase has been reintroduced with no recurrence of symptom. So now there's just one question: how many in the hall would do the same, or would like to shift to DOACs? Any taker for DOACs? So we have started again on pegisparaginase. So little background that we know that VT is less common in children compared to adults, but it has serious consequences in the form of death, recurrence of thrombosis, loss of vessel patency, chronic pulmonary hypertension, or post-thrombotic syndrome. We are getting more and more pediatric VT because of increased use of central venous catheter, improved survival in patients with chronic or critical conditions, and more VT diagnosis through improved awareness and imaging techniques. These are certain risk factors for VT, which are acquired and certain are genetic. Acquired will include line, surgery, ICU admission, prolonged hospital stay, mechanical ventilation, immobility, infection, acquired thrombophilia, chronic diseases, certain medications, hormonal therapy, and obesity. Whereas the developmental anomalies include the extremes of ages, inherited thrombophilia, anatomical thrombophilia, and inherited chronic diseases. So as we see certain difference in the pediatric versus adult VT, there is a physiological difference where we can see the level of natural anticoagulants are significantly lower at birth, which increases with age. And because of this age-dependent pharmacokinetic difference, the children respond differently to the anticoagulant from adult. We have certain challenges in managing this VT because the diagnosis often requires sedation or GA, limited vascular access for monitoring and drug administration, adherence is a specific issue, and lack of age-appropriate population. So, just overview of targets of certain anticoagulant. As we know that factor 10 antagonists are rivaroxaban, apixaban, and low molecular weight heparin along with unfractionated heparin. Here, these heparin they use antithrombin as a cofactor for their action, whereas these two, they don't need any cofactor. Coming to direct thrombin antagonists, which include dabigatran, bivalirudin, and argatroban. Vitamin K antagonists act through inhibition of vitamin K. So these are the classical anticoagulants which we have been using: unfractionated heparin, low molecular weight heparin, and vitamin K antagonists. The clinical data are usually for the adult which is available, and we generally rely on the extrapolated data from adult studies. Now, what are the shortcomings of these traditional anticoagulants? They have ultra short half-life for VFS, daily injections for low molecular heparin, delayed onset of therapeutic effect, prolonged time for this effect to diminish, narrow therapeutic window, multiple drug and food interaction. Need for dose adjustment to accommodate for dietary vitamin K content. The pharmacokinetic and dynamic actions of current anticoagulant are age dependent and thus require careful monitoring. Lack of age appropriate formulations. So, then what? What is the simpler alternative? Any oral? Yes, we have drugs which are directly active oral anticoagulants. They selectively inhibit the coagulation factors without need for a cofactor. The factor 10 inhibitors are apixaban, endoxaban, and rivaroxaban. Direct thrombin inhibitors are dabigatran. What are the advantages over the classical one? They can be administered orally, predictable pharmacokinetic, no dependence on antithrombin, fewer drug and food interaction, potentially reduced need for monitoring in children. These make drugs favorable for outpatient setting and for prolonged use. This is the table again showing the differences. I'm skipping this. So, are these drugs approved for pediatric use? As we all know, they are very well approved for adult. Yes, rivaroxaban and dabigatran are the most well-studied drugs, and they are approved for pediatric VTE and prevention of recurrent VTE in European Union and UK. Rivaroxaban is approved in Canada, whereas in US, dabigatran oral tablets and capsules are approved. We'll just go through certain key clinical trials with these drugs in pediatrics. So I'll focus on three main clinical trials relevant to us. Einstein-JR, where rivaroxaban was tried against the standard of care. Dabigatran, which is known as diversity trial, where dabigatran was used against the standard of care. Third is the Prevapix ALL, where apixaban versus no anticoagulation was used for prevention of VTE in children with newly diagnosed ALL. So this is how the flow of studies goes. I will just focus on these three important trials. Earlier they were phase 2 trials. So what is Einstein-JR trial? Here rivaroxaban was used against standard of care. It was an open label RCT where 500 children aging 1 to 17 years with confirmed VT were included. After 5 to 9 days of parental anticoagulation, they were randomized to 2:1 rivaroxaban versus standard of therapy, which was unfractionated heparin or low molecular weight or fondaparinux plus minus DKA. Total duration of treatment was 3 to 12 months or based on clinical indication. So they reported a types of VT, 25% with catheter related, 23% cerebral thrombosis, 51% other, and they found that the rate of recurrent VT was 1.2% in rivaroxaban arm and 3% in the standard of care. Higher complete recanalization with rivaroxaban on repeat imaging. They concluded that rivaroxaban did not have any major bleeding in that arm compared to the standard of therapy, and the pharmacokinetic pediatric exposure matched the adult levels at 20 mg daily with no clustering of PK efficacy or PK bleeding outcome. Tablets and suspension performed similarly well. They concluded effective, safe and comparable to adult data, and they support use of rivaroxaban in children with VTE, including cerebral vein thrombosis and CVC related VTE. Coming to the next important trial is dabigatran versus standard of care. Again, it is an open label RCT where 267 children were included after initial anticoagulation of 5 to 21 days. Randomization was 2:1, and the treatment duration was 3 months. The dabigatran was comparable to standard of care for VT recurrence, VT related death, and thrombus resolution, and pharmacokinetic and dynamic profile matched the adult pattern. Safety-wise, 20% severe adverse events occurred in the standard of care arm, whereas 13% had in the dabigatran arm. The most common adverse events were the vascular disorders and GI. On treatment, death occurred in the standard of care, which was retroperitoneal bleed, but it was not attributed to the drug. Major bleedings were similar in both groups. They concluded dabigatran is effective and generally safe with similar efficacy as compared to SOC. This is the third important trial which happened in ALL patients. It was an open label phase 3 RCT where they included 512 children with newly diagnosed ALL or lymphoma with a central venous line. Randomization was 1:1 with apixaban versus SOC. And they did routine USG at ECO at the end of induction and median follow-up of 7 days. The composite VT rate was 12% in the apixaban and 18% in the standard of care. Though apixaban showed a lower VTE trend, but it was not statistically significant. In coming to safety, major bleeding occurred in 2 in each arm, with clinically relevant non-major bleeding 4% in the apixaban and 1% in the SOC. There were total 5 deaths, 1 in apixaban and 4 in the standard of care. So they concluded that apixaban prophylaxis showed a trend towards reduced VTE without increasing major bleed, but epistaxis was higher in the apixaban arm. Overall safety profile remained acceptable during induction period. What was the problem with these trials? They excluded these patients. So they did not include the high bleeding risk, which are usually our oncology patients with active bleeding, platelet count less than 50,000. Specific comorbidities like active infective endocarditis, mechanical heart valve processes requiring anticoagulation, significant organ dysfunction in the form of renal or hepatic dysfunction, and specific neonatal age group where they were born less than 37 weeks. So, coming back to the case, where does DOAC stand in pediatric oncology? So, children with thrombocytopenia and bleeding risk were excluded from all the previous trial, and thus data regarding safety efficacy of rivaroxaban in cancer-associated thrombosis are rare. So, this is a case series published in PBC where it included 16 children aged 7.5 to 17 years, and they reported that thrombus resolution was comparable to the results of the previous studies. However, higher rates of thrombotic and bleeding complications were seen as compared to previous reports, especially among patients with relapse or refractory disease. This is another case report. So coming to the dosing regimen, they are oral and they have weight band. So in more than 50 kgs or more than 12 years, it is 20 mg once a day, whereas in less than 30 kgs, it is usually twice or thrice a day. Duration is, the standard is 3 months, but based on the condition, it can be extended to 6, 9 or 12 months based on the extent of thrombosis, ongoing risk factors or recurrence risk. In CDC related VT in less than 2 years, they have used it for 1 month, extended up to 3 months. These doses are based on the Einstein JR trial. Formulations which are available are oral suspension and tablets, given preferably with food. Avoid in renal impairment, hepatic disease with coagulopathy or active bleeding. We don't require routine lab monitoring, but assess for bleeding and ensure correct weight-based dosing. Dabigatran is again used in pediatric VTE, available in the form of oral pellets and solution and hard capsules. These are the weight-based dosing. Again, in more than 40 kgs, we use twice a day, and it is like body weight, we can decide the doses. The duration of treatment is 3 months, may extend to 6 months. Pellets are sprinkled on food. Do not mix with milk. Capsules must not be opened or chewed. Oral suspensions are available for small infants. No routine monitoring is required, though we require to check the renal functions periodically. And we have to watch for GI bleeding, as we found high rate of GI bleeding in diversity trial. The cost and availability, it is affordable based on the brand. The rates range from for a strip from 200 to 800, or for the higher strength from 200 to 2000. These are the price for the navigation capsules available, and these are available in both pharmacies as well as online pharmacies. So the key takeaways are that we know drugs are now established for pediatric PT more than 3 months of age. Rivaroxaban and dabigatran are the best evidence. It simplifies the anticoagulation with safety and convenience, and we need ongoing research to broaden the indications. Start with a structured assessment of age, weight, renal, hepatic function, concomitant drug users and indication. Low molecular weight heparin remain the preferred in many neonate and in situations requiring precise titration or immediate reversibility. DOACs simplify outpatient management of pediatric VT when approved and when child meets the safety criteria. For children with cancer, mechanical prosthetic valve, severe hepatic renal impairment or neonate, classical agents still remain frequently used, though we learned that we can still use in pediatric occupations. With this, I will end my talk and would be happy to take questions.
Thank you very much, Dr. Mandal. It is open to the discussion. Anybody wants to talk about?
Ma'am is right there.
So first of all, congratulations. That was a very nice talk. You really covered everything beautifully. So the only comment I wanted to make was that when we treat patients with these DOACs, there are definitely a lot of advantages. But with large studies in perhaps more in adults than the pediatric, we have seen that the serious bleeds are actually about the same when you look at it in larger cohorts. And what we see is that we do see a lot of GI bleeds, and we also see a lot of menorrhagia in the patients who are on DOACs compared to even vitamin K antagonists. So that is something to remember, especially if you have adolescents. The second thing I wanted to say was that when we have patients who are on ALL therapy, most of the time the bleed is not due to any underlying defect, it is due to either the chemotherapy or the lines and other things. So in the intensive period, we prefer to use low molecular weight heparin. Why? Because the patient may be getting L-asparaginase and other things, and also when we have to do intrathecals, you want to stop, right? So that is something that, and there might be thrombocytopenia and other things. And usually then after a couple of months, we don't, once the clot is gone, we don't need to put these patients on very long-term anticoagulation. So we often, for ALL patients, still are quite happy with low molecular weight heparin, and then we stop. But then we have other patients who need long-term anticoagulation. They may have AP3 deficiency or other underlying kind of things, and for that, I think DOACs are excellent. And again, you do have to counsel them about the menstrual and the GI bleeding. But I think the studies are definitely there to showcase that they are safe and are approved. And I actually like apixaban a lot, even though we don't have so much data on that in pediatrics. But in the adult patients, we're very, very happy with that product as well. So definitely a lot of new things that we can use for our patients and help them. So that was my comment. Thank you.
Thank you.
Thank you so much. Any other questions, everyone?
I have one more. मेरे पास दो चीज पूछे आपसे कि very good that we are now into the oral anticoagulants. My question is, we are all diverse. Now my question is, are any side effect universal agents? Suppose you are giving DOAC, you are giving DOAC. Now anything supposing they is there any agent given around that?
There are but availability of again, this is what I'm saying. The reversibility is little difficult. So unless we have the antidote with us, we should refrain in the highest situations.
Dabigatran was during COVID. It was too much used by my physicians. Dabigatran, because COVID reduced causing thrombosis. Now what happened? We have not much I want to ask you, or even Dr. Tulika, are we using it in the pediatric patient? Yeah, food is fine. Are you using it or not?
So, as I said we were just talking before, we were just discussing before. Yeah. So there's also several other problems with the direct anticoagulants. One is that many of my patients are very non-compliant. So you cannot tell if the patient is taking or not taking also. So with the vitamin K antagonist, you can monitor, you can say, okay, did you miss a dose? And they'll say, nahi, I've taken it. Then they'll say, acha, aapko kaise pata chala, maine miss kiya tha. So because you can look at the PTI now. So first of all, I would like to say the serious bleeding is very rare. You don't really need to worry about that if you have been given the dosing. But in case you do have a bleed, many times, even though we don't always have the direct reversal agents, you can go ahead and give FFP and other things and manage these patients. So most of the time, it's not an issue for pediatric patients. So that worry is not there. And since you mentioned COVID, there are studies where we looked at prophylactic anticoagulation, intermediate prophylactic anticoagulation, high dose prophylactic anticoagulation, and it didn't work. So again, you have to be very careful and look at the disease. Even in PNH, we find that prophylaxis doesn't prevent. What prevents thrombosis in PNH and COVID and other things is really treatment rather than towards the inflammation.
I was just going through literature. There are some much use of Gatra. Yeah, something they say used in the account disease also. If you have a lot of albinism, then to prevent that, you can use your anticoagulant. Then there is something like you have patient of let us say nephrotic syndrome.
Yes, definitely.
There you have
With thrombosis.
That's
Yes.
but as Reddy said, a lot of LFT has to be seen.
Hepatic and renal dysfunction. So with nephrotic and begin nephritic syndrome, we undertake renal.
Young pediatricians, they have the scope of using these. I just want to ask one more thing. Is there something like breathing? You start with the low one tablet, put on Previgen.
So the bridging is required when you're using vitamin K antagonist because when you start vitamin K antagonist, the protein C, protein S goes down initially, so you need to do bridging. With the oral direct anticoagulants, you don't need to do bridging. You can start immediately.
But the studies they've used like 5 to 21 days of parental before going on to DOACs. So
That is probably because you want to get the clot to be dissolved faster. But
Thank you.
Thank you, Dr. Mani, for that clear and informative start for the session. Our next speaker will take us to advancement in managing ITP beyond IVIG and steroids. We have Dr. Mukesh Thanka with us. He's DM Pediatric Hematology Oncology Professor at Lady Hampton. Can we have a round of applause? Thank you.
You are now the youth member also.
Sir, thank you, sir.
He's a youth member. And he's a professor of pediatrics in the Lady Medical College and that is DM from PA. Sir, please, topic is open for you.
Right, sir. Thank you. Thank you, Vikas, for this opportunity. So, my task is to talk about ITP, that too beyond IVIG and steroid, where most of the people just talk and say, now you are referred to Tulika ma'am. So, I am also given this task of dealing with such kids where chronic, refractory, or something when we have some side effects or some specific subsets of patients. So, I will try to do justification to this talk. So, when do we start looking for IVIG, beyond IVIG and steroids? In conditions when it is refractory or recurrent, when there is steroid dependency or when we see toxicity of steroids, when there is no response to IVIG or there is limited availability when supply is not there, and I know that when supply is not there, because everything is free of cost in our hospital, so when supply is not there, it becomes a concern. And when we need to look for the long-term safe options. So let's see, I will be going through these things, thrombopoietin receptor agonist, the most, I will be talking most about it, then it is rituximab, other immunosuppressants, splenectomy, yes, but rare now, and some emerging agents. So TPO receptor agonist, so to summarize about this TPO receptor agonist, I will just say that the first line of this chronic refractory cases, I would like to recommend the use of TPO agonists straight away. So there are various TPO agonists available. We'll talk about them one by one. So these TPO agonists stimulates the thrombopoietin by thrombopoietin receptors. There are three which are available: eltrombopag, romiplastin, avatrombopag, So all these three are available, all are FDA approved. This avatrombopag is not approved by European Union but approved by FDA for the use of pediatric age group, but beyond 1 year of age. Beyond 1 year of age. So let's talk about avatrombopag first. So as it stimulates by thrombopoietin, so beyond 1 year we can use it. For 1 year to 6 years, up to 6 years, less than 6 years, the initial dose is 25 milligram given once a day. It is an oral drug. Beyond 6 years or beyond, it is 50 milligram from where we start. It has to be taken empty stomach without 2 hours before and 2 hours after. It has to be empty stomach, and dose is adjusted in the increment of 12.5 milligram every 2 weekly, and the maximum dose as per the guidelines is 75. Though there are some case series or case reports of some researches in which higher doses are used, but recommendations are of only 75 milligram per day. So this is how we titrate avatrombopag. So the starting dose, as I mentioned, was from 1 to 6 years is 25 milligram per day. For more than 6 years, it is 50 milligram. It is 50 milligram per day. And for East Asian ancestry, which is not for our country, it is for countries like Philippines and all that. There the dose is lower because that studies categorically enroll those patients, but it's not for Indian patients, so don't count us into this group. So if it is less than 50, we increase the dose by 12.5, maximum is 75, and we recheck the platelets after 2 weeks. If it is between 2 lakhs to 4 lakhs, we reduce the dose between 12 to 12, decrease the dose by 12.5, and if it is more than 4, we hold the dose, and if it is more than 4 lakhs, on the lowest possible dose for 2 weeks, we discontinue medications. So adverse effects, commons are like headache, myalgia, mild GI effects, which are insignificant, which we should not be a concern to discontinue. Hepatotoxicity is a concern, drug specific. It is usually reversible transaminitis, and in 3% of the cases in PETI 2 trials had to discontinue this drug, so we require LFT monitoring. Cataract, yes, a reality, it's rare, but it's often seen only when there is a concurrent steroid use. No risk of neutralizing antibody formation as in cases of romiplastin, and no clinical significant bone marrow fibrosis is reported, as in some cases, rarely it has been reported along with romiplastin. Efficacy, so if we try to analyze both PETIT 1 and 2, there is decreased bleeding. Platelet counts have been relatively on higher side and lesser use of rescue medication. PETIT 2 specifically showed durable platelet response, which initially was 6 weeks, to PETIT 2 it was 12 weeks, so it was 40%, and 81% achieved platelets more than 50,000. But in real world, probably 60 to 75% response, which may be slightly kind of being more ambitious. We hope we will have more because it is slightly less than what the trial said, and the response may vary due to dietary building rules. Question: how long should we give it? So, anybody? We don't know. We don't know how long to give, but we know when to discontinue. If it's not responding for 8 weeks at the highest dose, we tend to stop it because we don't expect the response. But to how long to give, we don't know. And when we stop, whether the child would continue to have response or the child would again relapse, we don't know. It would vary from child to child. Coming on to the next drug, romiplastin. So the initial dose is 1 microgram per kg subcutaneously weekly. The goal is to maintain more than 50. And how to titrate? If it is less than 50, we increase the dose by 1 microgram and recheck in 1 week. If it is in 2 lakhs to 4 lakhs, we reduce the dose by 1 microgram and recheck in 1 week. If it is more than 4 lakhs, we hold the dose and recheck within 1 week, and resume only when it is less than 2 lakhs at reducing the dose by 1 microgram per kg reduced dose. And if it is more than 4 lakhs, at the lowest dose for 2 weeks, we discontinue. So common effects are headache, mild GI symptoms. Antibody formation, which is unique in this drug, is seen in up to 2 3%. Thrombosis is rare. There is no hepatotoxicity. It is not related to empty stomach or something. It is to be given once a week only, and no clinical significant bone marrow follow, though it is reported. Long-term safety generally is excellent. Again, the platelet count was more than 50% seen in 60% of the cases, 68% of the cases. Long-term also we have a similar good response, though this more antibody-mediated loss of response is seen in children. How long is to be given? Say, we don't know how long. But again, we know if there is no response after 8 weeks, we at the highest dose, we tend not to continue further because we don't expect the response thereafter. But how long it is to be given and how long the response would be there after stopping this drug, we don't. We still don't have an answer. Ever thrombopac, this is the latest edition of thrombopoietin agonist. Okay, coming on to the cost, which I missed. So, eltrombopag cost is one tablet may cost from 70 rupees to up to say 250 to 300 depending on brand to brand. One tablet. Injection romiplastin cost of 250 microgram vial would vary from 1200 to 2500 depending on company to company. And this ever thrombopac comes in the bottle of 28 tablets, and this costs somewhere around 20,000. That means 700 to 750 rupees one tablet. 20 milligram tablet, one tablet would be 700 to 750 rupees per tablet. So this is relatively expensive and latest in our list of TPO agonists for ITP. So tablet is to be given for more than 6 years of age, and the sprinkled granules are there if it is less than 6 years, and it must be administered with food. So sprinkle initial doses is 10 milligram once a day, maximum is 20, and for more than 6 years it is 20 milligram once a day, maximum is 40. Titration, we tend to maintain the platelet above 50,000. Increased dose if platelet is less than 50,000 after 2 weeks. Decreased dose if platelet count is between 2 lakhs to 4 lakhs, and we withhold if it is more than 4 lakhs. Weekly platelet checks until stable, then monthly monitoring, and after stopping, monitor weekly for 4 weeks. Always take with food. For sprinkled granules, there are specific instructions. Open capsule and mix with soft food or liquid. Do not chew or crush granules. Administer immediately. So there are few side effects which are not that significant: headache, mild GI symptoms. Thrombocytosis is a concern, and in up to 40 cells, so we have to monitor the child. No hepatotoxicity, no antibody concern, no thromboembolic events, and generally well tolerated. Efficacy, yes, again it is a good efficacious drug, showing up to response of 81%, sustained response of 28%. Lower rescue therapy use is seen, and in real world 73% response within 12 weeks. Effective even in children who fail. This is very important. This is even effective in children who even failed previous TPO agonists like eltrombopag or romiplastin, and it demonstrates cross responsiveness even after romiplastin or eltrombopag shows no response. So, how do we counsel? Should we take oral drug or should we take weekly subcutaneous injection? So, what we do, and Dr. Pelli and we do is we sit down and counsel the parents. The choice is theirs. In this, we have concerns of taking it in the stomach. Here is a concern that you have to learn the art of taking subcutaneous. Here it is daily. Here it is once a week. You have to monitor there twice weekly. Here you have to monitor weekly. So the choice is given to the parents. In our hospital, both are in supply. So money is not the concern. It is the choice of the parents how they want to do it. We leave up to them. Coming on to the rituximab, the second I would say the preferred thing in cases of the chronic refractory ITP. So it is an anti-CD20 monoclonal antibody targeted in B lymphocytes. They do not target plasma cells, used in persistent chronic pediatric ITPs. This is from observational data only. No randomized pediatric trials I could find, and these evidences are extrapolated from adults. Typical dose is 375 milligram per meter square weekly for 4 weeks. Higher doses or lower doses have also been used. We pre-medicate with methylprednisolone. Subcutaneous, this was interesting. I have never used this. Subcutaneous infliximab exists, but I'm not aware whether there are limited trials. But adults, yes, I could find few. The response rate is from 40 to 50%, long term in 25%. The response, we are able to respond clinically the effect from third week of starting rituximab. Higher response in adolescent females. Adverse can be reactions to the infusion reactions, serum sickness, hyperbilirubinemia. So, few precautions. HPV screening is required. There is a risk of reactivation. You have to check the immunoglobulin levels because there are, after giving this, there are long, we don't know even for years, the immunoglobulin levels will be low. Vaccination, we have to avoid like vaccines until more than 6 months after giving it. Other immunosuppressants are like MMF, azathioprine, cyclosporine, their roles, we do not know much. The case studies and case series. They may be used as steroid sparing for chronic ITP, limitations, slow onset, monitoring required. We do not know whether the patient would respond to them or not. Splenectomy reserved for only chronic persistent is unresponsive to all other aspects. We try to avoid at all costs. High long-term remission rates, concerns like log infection risk, vaccination and prophylaxis are essential. But now partial splenectomy is also a reality. So even if we need partial splenectomy would be a better option. Other evolving therapies, we do not know much about them, but this, they are important for us. And other supportive care, we avoid NSAIDs, contact supports, we treat infections promptly, manage venereal and adolescent girls, with also the family and follow-up planning. So, first line, we know steroids plus minus IVIG. If non-responders or steroid dependent, we tend to start with thrombopoietin agonist. If inadequate, we consider the rituximab or the MF and rarely splenectomy. This is my take on ITP regarding beyond steroid or IVIG. So, pediatric ITP increasingly managed with long-term safe agents. TPO receptor agonists are preferred second line. Rituximab immunosuppressant remains useful and splenectomy reserved for selected cases. Thank you.
Well spoken, Dr. Lankar. House is open for discussion. Any questions? Well, I have one question to you.
Sir.
You said rightly that there is no limit for this stopping. Now my question is, there is some mention about the rebound thrombocytopenia. Supposing you stop the drug, maybe after some time, have you come across, because it was when I was reading through, there's some mention about rebound thrombocytopenia after stoppage of these drugs. What is your take on that?
Sir, my take on this is, as Dr. Pyari ने also been remembering, जो हमारे केसेस है ना सर कलावती में जो हमने ऑब्जर्व किया, approximately 50% तो thrombocytopenic हो जाते हैं after stopping it, and 50% remains normal, approximately. We are compiling the data, मतलब approximately which we remember.
Thrombocytopenia बहुत बड़ी problem.
हाँ, then we restarted. उनमें से जो मुझे approximately याद है, उनमें से 50% ने respond किया दोबारा में भी. दोबारा में
be very clear about it.
I don't know why.
I noticed rebounds have thrombocytopenia. I have not been much, but I've used about 3-4 patients. One child had rebound thrombocytopenia after stopping the drug after 6 to 9 months of the therapy. I would like, what is the Turika says?
Maybe would be in a better position.
I think that was a lovely talk. You covered everything very nicely. But since you asked the comment, so what we always do is we taper the drug. The rebound thrombocytopenia happens quite often on patients who are paying and then they either don't have money or they suddenly stop. So if you're on a high dose and you suddenly stop, you're more likely to get the rebound thrombocytopenia. If you taper,
how long you would like to
it takes a long time. We taper over months. We don't taper, so if you're on 50, we'll go down to 25, we'll go down to 25 alternate day. No, we taper. Then there's no this thing. And as you rightly said, there are now papers where about 30 to 40% patients who are on long-term TPO agonists, when you stop, they maintain their platelet count. The only other comment I just wanted to make is on rituximab. So we see a lot of patients from other centers and they come to us And many times these are small pediatric patients and they receive 2 courses of rituximab. So I think it is not a good idea to keep giving rituximab to patients. And in many of these patients, they've not had a complete workup for thrombocytopenia. And in some of these patients, we found that they actually were not ITP even. And to get 2 courses of rituximab, I think is not the right thing to do. People may object to my criticizing, but that is my feeling. They can have common variable immunodeficiency, they can have ALPS, they can have familial thrombocytopenia. We are now doing NGS in many of these patients that were labeled as ITP but never got a very good response. So if you give some therapy, the platelet count goes up to 50, 60 but doesn't get normalized, and this is an ongoing process, take a look, it might be something else, because that's something that we are now finding with many of our patients that we had also labeled as chronic ITP, we're now finding that they had something else.
Probably my take on this would be, if we have a secondary ITP, probably related to SLE, or EVANS or ELPS, probably I would choose that child for rituximab, else I would refrain from giving rituximab in ITP. No, no, very rarely. And specifically when we have this setting where we find this, other drugs are not going, then I would like to give rituximab in this subset of ITP patient, not otherwise.
To meal, this is just one thing that during this rainy seasons where they get more lots of hepatitis A, patient non-rituximab, they develop like delayed OTPT and everything, and we have to suddenly stop it. So again, that may lead to rebound thrombocytopenia and bleeding risk with coexisting A infection. So one has to be careful with that as well.
Thank you, Dr.
Thank you, Dr. Dhanwar, for that valuable insight. Moving forward, I would like to invite Dr. Tulika Seth and to speak on TPO against beyond ITP. Can we please welcome Dr. Tulika Seth?
Well, who does not know Dr. Tulika said, you can see how much is written there. What Tulika said. So, may I
Sorry,
invite
what you
Dr.
think,
Tulika
sir?
said, you start.
I am just very old, sir. So thank you so much. It is such a pleasure to be here, and this topic was assigned to me, so I'm not sure what Vikas wanted me to talk on. But Dr. Dhankar has made my talk very much easier by going over all the TPO agonists very well. So just a little bit of history. So thrombopoietin we know is produced in the liver and the kidneys, and the nipple receptor is very important, and initially thrombopoietin itself was used as a drug, but then they found that a lot of patients developed antibodies, so that was not useful. Then because people had identified the nipple receptor, people then developed drugs that were receptor agonists, and unfortunately the first generation TPO receptors were not very good. So then now we have the second generation thrombopoietin drugs, and of which we have TPO peptide mimetics, of which romiprostin is the one that we are using, and we have non-peptide mimetics like L-thrombopep, and there's probably going to be even more drugs in the future. So the role of the TPO RAs are quite broad. The primary mechanism is platelet production, and that of course has been beautifully discussed already. The mechanism for romiprostin and L-thrombopeg are slightly different, but in all what happens is you have increased proliferation and maturation of the megakaryocyte progenitor cells and inhibition of apoptosis of these cells. And ultimately the result is that you have an increase in platelet production. You also have an increase of hematopoietic stem cells, megakaryocyte progenitors, and mature megakaryocytes. So this role of the hematopoietic stem cells is used now because, as you all know, these are approved in aplastic anemia as well. The other thing that it does is that we often don't talk about it, is has a secondary mechanism in immunomodulation of the Treg cells. So in ITP, we know that these patients will have lower Tregs, and that is one of the reasons why they have the autoimmune destruction of the megakaryocytes. So L-thrombopeg in particular has been well described as restoring and increasing the activity and the number of the T regulatory cells, and it restores the immune tolerance, and maybe again this could be one of the reasons why it works in aplastic anemia as well. So the usual areas where as hematologists we're using the TPO arrays are chronic and persistent ITP, and there's now also good data in acute ITP as well. And for acquired severe aplastic anemia as frontline triple therapy, and also in relapsed patients of acquired aplastic anemia. So these are the usual approved indications. The other indication is for hepatitis C associated thrombocytopenias, and for which avatrombopag is very important, but you can use the other agents as well. Now, I'm going to talk about the off-label and the other uses because everybody's familiar with the common ones. So, one of the things that we have used a lot is chemotherapy-induced thrombocytopenia, though romiplostin is approved for that. But we have used L-thrombopag and romiplostin both, and there are many case reports and KCV supporting that. The other area that all of us may have used in some cases is in post-hematopoietic stem cell transplant-associated thrombocytopenia as a poor graft function. In the ICU and in dengue infection, also there is some data. Thrombocytopenia secondary to patients who have myelodysplastic syndrome. Often we have elderly patients or pediatric patients where the thrombocytopenia is so severe that it's difficult to even send these patients homes. And lymphoproliferative disorders. There are also inherited platelet function disorders like MYH9 related disorders, Wiskott-Aldrich we talked about, X-linked thrombocytopenia, and other inherited thrombocytopenias. And also there is some reports in inherited bone marrow failure syndromes. There is a mention of it even in neonatal alloimmune thrombocytopenia, but I was only able to find one case report on that. So we know that the mechanisms of thrombocytopenia can be different in different conditions. In inherited bone marrow failure syndromes and aplastic anemia, leukemia, chemotherapy induced, it's mostly decreased platelet production. In others, it might be ineffective production, or there's increased destruction, which we would see in ITP and HLH, or increased consumption, which we would see in MAHA and TTP and HUS, or sequestration, which is there in hypersplenism, and in many conditions you may actually have two or more of these things going on simultaneously. So romiplostin is a recombinant Fc peptide fusion protein, and so I won't go into that because it's already been discussed. It has very few drug interactions that are relevant to pediatrics. For those of us who treat adults, lenalidomide, pomalidomide, carfilzomib, thalidomide are multiple myeloma drugs, so you have to be careful with that. Some patients do develop neutralizing antibodies, and romiplostin may not work in those patients. L-thrombopag is a small synthetic molecule, and it's a non-peptide. Because it's a non-peptide, antibodies are less likely. But there are a lot of drug interactions, and of course we already know about the dietary restrictions, so you have to be careful if patients are on antacids or calcium or imatinib and DOACs, and you have to use lower doses if patients are on steroids and danazol and azathioprine. So in fact, there's over 214 different drug interactions. So if you have patients on a lot of drugs, this may not necessarily be the right drug to choose. What's the difference between them? So one is the receptor that they work on is slightly different. Romiplostin is an extracellular domain of the TPOR, and L-thrombopeg is a transmembrane. The potency is also a little bit different, and so this we have had patients where they were on L-thrombopag and they didn't respond, and they responded to romiplostin. So we've had patients vice versa also. So if a patient has failed one, it doesn't mean you can't use the other. In this paper, by Dr. Kucha's group, they actually kind of showed that romiplostin is a little bit stronger, but whether that translates into clinical efficacy may or may not always be the case, but you can use it. So some studies on the other indications. So the chemotherapy-induced thrombocytopenia, romiplostin has been the most studied in that, and that it has a approved label indication for it. And in patients, there were several studies in which patients who were on it for chemotherapy-induced thrombocytopenia, 93% these patients did respond to that, and usually within a few weeks. And these were all significant studies. The number of patients who were on this, only 6.8% experienced chemotherapy-related dose reduction. So if you want to maintain chemo intensity, this is something that has been evaluated and studied. There are also, in solid tumors also people have used it. So again, very excellent response rates in these patients. But again, patients who have chemotherapy-related thrombocytopenia due to solid tumors will have a normal healthy marrow. So it's not surprising that they will have a good response to the TPO-RAs versus patients who may have leukemia or other things where the marrow may not be affected. And patients who were having solid tumors, 79% avoided dose reductions and treatment delays, and 89% were able to avoid platelet transfusion. So I think that's very good if you have patients who need this. These are just some more case studies on this. So, and this is showing you how patients who were on romiplostin were able to have higher platelet counts and sustain that. And are they used? So how do we use them? If we use them, it's pretty much the same as the dosing that we would use in ITP. Maximum dose for romiplostin would be 10 micrograms per kilo. For L-thrombopag, though it's not approved, but there are several case series where they have used doses varying from 25 to even 100 milligrams per kg in different case reports. So again, if you're using this, it is off-label, and but sometimes you're in a dire situation. So these things have been used, and they are fairly safe. The only thing you need to worry about is that there might be an increased risk of venous thrombosis because these are active cancer patients. So you need to monitor these patients, and these are the NCCN guidelines, where also they have put the TPO-RA and separately as clinical trials, and romiplostin as an approved thing for supportive care for chemotherapy-induced thrombocytopenia. Then we have hematopoietic syndrome and acute radiation syndrome. There again, romiplostin has been shown, and this has several mechanisms of action where it is able to reduce the lethality and the pancytopenia by multiple mechanisms. And it has even been used in combination with GCSF and recombinant erythropoietin. So there is some data on that, and the usual dose is 10 micrograms per kg. So here you don't do a dose titration, you simply start off with 10 micrograms per kg, and it can be used after patients have gotten radiation therapy. Chronic liver disease is something that all of us have seen, and though avatrombopag and lusotrombopag are the drugs that are approved, we have had limited access to these drugs, and in our experience at our center, we have used romiplostin a lot. Thrombopeg, I tend to try to avoid, though there is some data of it with hepatitis C, but because romiplostin does not cause hepatic dysfunction, for many of our gastro patients, if we get consultations for these patients, we recommend that they get romiplostin for thrombocytopenia, either when they're on hepatitis C treatment, or they need surgical procedures, or they have other issues. The peri-surgical experience for romiplostin is very good at our center. We get a lot of consultations from different surgical specialties, right from neurosurgery to gastrosurgery, and we have used both of the TPO-RAs. Romiplostin slightly more because it's easy to give during the peri-operative period. It's an injection, it's not an oral agent. And hematopoietic stem cell transplant also, there is a lot of data. We use it very frequently, particularly in our thalassemia patients if they have poor graft function, and it is able to improve the platelet count as well as all the other cell lineages. And the doses are again very similar to what we use for romiplostin in our conventional ITP patients. In L-thrombopag, various doses have been used, and doses up to 150 milligrams, which is the dose that we would use in aplastic anemia, have also been used in patients, and you can titrate according to the response. In MDS, which is rare in pediatrics, but the lymphoproliferative syndromes are also rare, but these are again very challenging situations, and sometimes it is the disease and sometimes it is even the therapy that can lead to thrombocytopenia, and here again these agents have been very useful. There's a large group of inherited thrombocytopenias that we've been missing, but now that NGS and other technologies are available for us, we are now finding many of our patients that were labeled as acute ITP are actually not acute ITP, and many of these patients have these mutations. So, will the TPO-RAs work in them? There is some data to show that viscous outreach patients may respond. MYH9 related disease, we've had several patients who are identified with this, they can respond. ANKRD26 patients can respond. So there are these are not large studies, they're case reports of patients, and if you have that, so that again makes it a little bit confusing because you may have labeled them as ITP and they may have a response to TPO-RA to some extent, and but it's still good to go back and check if these patients are there. In the ICU, we get a lot of consultation because a lot of sick patients may have thrombocytopenia. We often find it is related many times either to sepsis or to the antibiotic use, and drug-related thrombocytopenia can again work in different mechanisms. It can either be direct drug relation or immune. So there's multiple reasons why ICU patients have thrombocytopenia. So it's important to understand why it is. I mean, are you dealing with a hit? If you're dealing with a hit, then using a TPO-RA is not going to work. But there may be other conditions where a TPO-RA will be beneficial. So these consultations actually need a lot of thought, and you need to investigate what exactly is the cause. But in many patients, especially if it's sepsis related, where it might be either due to bone marrow suppression or due to other decreased platelet production, the TPO-RAs can be used, and both romiplostin and thrombopeg have had data. When it comes to infection, again, there's many reasons why you can have thrombocytopenia, and during the COVID period, we started using TPO-RAs frontline because we did, especially in ITP patients. And I think from there, a lot of people then thought about using it in other things, and there are some case reports of the use of romiplostin in dengue patients, particularly if the platelet count doesn't rise as they want. And this could also be because we have seen in post-dengue patients, we've had some patients who presented with pancytopenia and bone marrows were done, and they were absolutely aplastic. But eventually these patients do recover. This is bone marrow suppression due to the infection. But for these patients, you can use TPO-RAs while they are recovering. This doesn't happen very common, but there have been some patients who develop bone marrow suppression. And so these are some of the articles. This is from Pakistan, where they used it in some of their patients and they found it was good. In HIV-associated thrombocytopenia, the first-line treatment are the HIV medications. However, there are some patients where the thrombocytopenia may be persistent, and in those patients, there have been again some case series where they have used the TPO-RAs for these patients with refractory thrombocytopenia. I found in several references that the neonatal autoimmune thrombocytopenia, it was used. However, when I searched, I could only find one case report in which they had a patient who got platelet transfusions and IVIG and was not responding, and they used some romiplostin for 4 doses for this patient. But there's only one case report, so again, it's not definitely not frontline therapy, but they can be things. So there are obviously practical differences, and that has been beautifully described. And whenever you're doing tapering of romiplostin, it's very important for romiplostin in particular to do a slow taper, because otherwise you may see the rebound thrombocytopenia that Dr. Gomber had mentioned. And you should monitor the platelets after you've discontinued to make sure that the patient does not get the thrombocytopenia. The hepatic and renal impairment, you need to see what's going on, because for mild hepatic dysfunction, you can go ahead and give. Mild renal dysfunction, again, you can go ahead, you don't need any dose modification. But if there's severe hepatic or renal, we don't have any guidelines. Now, what about congenital amegakaryocytic thrombocytopenia? Classically, it's not supposed to work because it should actually not function in this disorder. But there are some patients where they have a receptor that's non-functional or absent, and so in some patients it may work. So I guess what I'm trying to say is that you can give it a try. If it doesn't work, then that's fine. So again, this is like a little bit of an overlap kind of an area. So there may be some patients who have missense Whipple mutations where it may work in those patients. There are some trials ongoing for inherited bone marrow failure syndromes. We don't really know if patients, where it will work or not. So ideally, it should be done only in a clinical trial for these patients because we don't have any data for this. So overall, we have approved indications where it's very likely, like IDP, plastic anemia, hepatitis C, chemotherapy-induced radiation, and peri-procedural. So there we do have more evidence. In other cases, there's a little bit less evidence, but when you're up against the wall, and platelet transfusions in our country are always very difficult to get, so you can definitely think about it. So in summary, thrombopoietin is involved in multiple steps in platelet production, and it's important to understand the etiology and the mechanism of thrombocytopenia in the patient that you're dealing with. And TPRAs increase not only the platelet production, but they also may monitor the immune mechanisms and thereby decrease the platelet destruction. We are all using it in IDP and aplastic anemia, and we have other indications where they may not be approved as yet, but we can contribute to that level of evidence. So if you have used it in an unusual scenario, do publish that and contribute to the field, because it's an expanding area and we do need to have a lot of evidence to base our therapy. So with that I end. Any questions, I'm happy to answer.
Then, Dr. Zulika, you have extended the indications of romiplastin and ectramopag. Well, I have something. I think the carry-on message should not be, as he rightly said. Supposing there is a patient in the ICU, you have to treat the infection first. Don't be put on the romiplastin or ectramopag. First, you have to find out the cause of the, as you rightly said, the cause of the thrombocytopenia and treat the cause. Yes, there may be some stray case reports about dengue, but I would not say that for dengue you start using it. Fluid therapy, common things will stay common. But yes, you have the options now of many other drugs. Well, this was a comment which I wanted to make. One more question I was wanting to ask you, that when you are giving for aplastic anemia and for IDP is okay, but supposing you have a patient of MDS and you try or you giving the TPRAs, will they not induce the production of the blast also, and will have the problems also?
So generally, low-risk MDS patients, people have actually even looked at GCSF, and there's not been any kind of risk in
Like
that.
you see in the ALL also, we don't try to use all these CSF or during the induction because there is a likelihood that they may go in for the production of both of the blasts. So will that not also apply? Though the MDS is not very common
So
in pediatric.
I will contradict you a little bit. In the ASCO guidelines, in ALL, you can actually use GCSF.
That is right.
Yeah.
But will that not be the increasing of the blast as well?
I think short term, if you're having a problem, it can be used. I definitely would not recommend very long term use of this. I agree with that. I mean, short term, it's fine.
Thank you very much. Any questions from anybody?
Yes, sir. So, like as you mentioned, like I also had a patient in NICU was gone through IVF delivery, had sepsis. But when sepsis was resolving, the sepsis parameters were also resolving, but platelets were constantly in the range of 5 to 10,000. And the neonatologists were very apprehensive, like do something. So, is it right to use romiplastin in that situation?
So I think I would do a bone marrow and just see what exactly is going on. The other thing is that a lot of antibiotics themselves lead to thrombocytopenia, and most of the time the consultation that we do in the ICU, we will say we don't start TPORAs and other things. We will often say change the antibiotic. And the intensivists are like, no, we need this. So we're like, okay, show us the culture that you need only this antibiotic, because there may be the pathogen may be sensitive to other antibiotics. And often all you need to do is change the antibiotics. Also, after you have like severe sepsis in a newborn, you may have some bone marrow suppression. So again, it depends on the situation. If the patient's had an intracranial bleed and you're worried that there might be another intracranial bleed, you're not able to give platelet support, I think it could be, if you stopped all the antibiotics, you could use it for a short period of time. Yeah, I think 1 or 2 weeks is not going to change.
You want to say something?
Yes, sir. regarding you, I just wanted to say we can see the CBC also, like parameters like immature platelet fraction. That can also help whether it is the destruction or the increased production.
Absolutely right, yeah.
So baseline, we see things first.
Yeah, here comes the role of IPF, in which you are better. So sometimes it happens after a few days, the child improves, and you have that now you have the counters, you have the IPF.
The advantage of doing a bone marrow though is that you could see if the bone marrow cellularity is low or other things are also there. So, but yes, definitely the immature platelet fraction is definitely good for dengue. That's where it's really been studied.
So, like in chemotherapy-induced thrombocytopenia, at what time point you take a call to start TPO agonist? Like we know that it's the drug effect, we have ruled out other causes.
So frankly, in leukemia lymphomas, we are not using in leukemia, definitely. Lymphoma patients, most of the time the regimens that we're using, we don't really need it. These are just the references. So I don't know, solid tumors is where it's kind of been studied the most, but we don't treat solid tumors. So I think you would be able to tell us on what is the best. But I think if you have like severe thrombocytopenia, it's going on for a long time, particularly in patients maybe who are at risk for intracranial bleed, or you are, for us, our biggest problem is platelet transfusions are not always available. But again, most of these, I think the reason why I wasn't very excited about it is because we know from practice it takes 1 or 2 weeks for these agents to work. So it's not like an immediate thing. It's not like, if I have somebody who's bleeding, I know if it's ITP, I can give steroids or I can give IVIG, and within 24 to 48 hours I'll get a response. Here it's going to take time. So again, it's like GCSF. You will get a response maybe a few days earlier. You will not get, so that period you still have to break.
So mostly for solid tumors to compress the time interval and
Exactly.
like
To keep the dose intensity.
Yes.
Thank you, madam.
Always. 100%. Absolutely. Yeah. So that's what you mean. But you have something that where if you know the cause, you can add something.
Thank you, Dr. Tumika Seth, for such an enlightening presentation. And thank you, Dr. Sunil sir, as well. Next, we have Dr. Rajat Bhattacharya with us. He's a senior consultant, pediatric hematology oncology BMT at Apollo Multispeciality Hospital, Kolkata. And he's going to speak on TCR-AB depletion in benign hematological disorders. So can I please invite Dr. Rajat Bhattacharya on stage, please? Oh, he's already there.
I'm already there. I had no problem with the formatting. So unfortunately, I just learned that I have to change it to aerial format. I hope it works.
थोड़ा तेज बोलो ना यार, सुनाई दे मेरे को यार।
Okay. Yeah. Thank you, Vikas, for inviting me, and it's great to be here because we learn from each other. And what I'm going to talk to you about in the next 15 minutes or so is TCR alpha depletion in benign hematological diseases, and I'll tell you what I've learned in the last 11 years since 2014. We started doing it in Singapore, and it's great to see Ernest, my co-founder from Singapore, and we have a Singapore connection with Vikas. So I'm going to slightly change the topic to selective T-cell depletion and benign hematological diseases, and this will be my outline of the talk. I'll do a bit of introduction of the immunological basics of transplant and how the evolution happened in the ex vivo T-cell depletion and how personally I've learned through this depletion process. And what are the current results of the T-cell depleted HSCT in benign hematological diseases? And I'll show you a few slides about my personal experience in Apollo since the last 2.5 years I've come back to India. And some practical tips and pitfalls which I've learned through the process where things went wrong. And what will be the future of the graft engineered stem cell transplant. And then I'll do some research. So introduction, very basics. You all know about this CD34 positive stem cells you need to give for engraftment, but remember the graft facilitating cells. These are the gamma delta, the NK cells, the dendritic cells, Tregs. They also help in engraftment. It's the recipient alloreactive T cells which will cause graft rejection. It's the donor's T cells which cause GVHD, and the donor T, B, and NK cells will help in your immune reconstitution. But then we don't think much about other cells, NK cells. Bernice is an expert in the NK cells. They are killer of the naturally infected and cancer cells. They don't cause GVHD. And in alpha beta gamma delta, remember 99% of T cells are alpha beta. They're reactive to cause GVHD. There is a gamma delta cells which are 1 to 9%, but they become very important in this type of transplants. And they don't cause GVHD and will help in immune reconstitution. And then you think about the 45 RA and RO, and roughly about 50%. The older you get more RA, which is the RO, which is the memory T cells. The younger you have more naive T cells. And the naive T cells will cause GVHD, but the memory T cells supposedly will not cause GVHD, but will provide you with the antiviral and anti-leukemia effect. And then also the T regulatory cells, which regulates all the T cells and reduces the GVHD and autoimmunity. So these cells become important when you're talking about the selective T cell depletion. So I'm going to highlight these T cells, the NK cells, gamma delta T cells, the memory T cells, and the T regulatory cells, and show you how they are important in this type of transplant. So when you look at the T cell maturation, T lymphocyte maturation, they go from the naive T cells to central memory, effector memory, and terminal effector memory. So when you have a naive T cell which is RA positive, and they have a high GVHD potential, but as they become central memory T cell, they lose the 45 RA and become RO positive, but they still retain the CD27L, 27 and CD62L positivity. So they have GVHD potential, but they also have the antiviral and anti-cancer effects. When they become the effector memory T cell, the GVHD potential probably reduces much more, but they still retain the antiviral and anti-cancer properties, but they now lose the CD62L. And when they become the TEMRA cells, they regain the CD45RA, which is, that's why I call that terminal effector memory, RA positive. So they have literally no GVHD potential, and they will have the antiviral and anti-cancer properties. So these are the things which you need to remember while doing this. NK cells, this is from my boss, Professor Wing Leong, many years ago. They are very important in the sense of transplant. So we have an end donor and recipient NK mismatch. The donor NK will kill the recipient dendritic cells, will reduce the risk of GVHD, kill the recipient's T cell, will reduce rejection, kill the viral infected cells, will reduce the risk of infection. And we're not talking about leukemia, but they have a major role in reducing the relapse. Gamma delta cells, just about 5% of your T cells. This is a nice article which showed that 1984 it was described and people are starting to understand how they work. In 2004 they were designed for CAR gamma delta, which is now coming up in big time. And we know that they have anti-leukemia properties. So they have a ability to kill the leukemia cells. So they're very peculiar cells. If you look at the TCR structure, they look like an adaptive, because they express the gamma delta T cell receptor. But if you function like the innate cells, they function like defined by the gene set. So they function like the innate immunity cells, and they have anti-tumor, pro-tumor effect. And if somebody is here, 35 years old, be happy that your gamma delta T cell are at their best. After that, the gamma delta T cell numbers and the effectivity becomes lower. And last cell is the T regulatory cells. Very, very important, because the gamma T regulatory cells will have effect. They'll have the immunosuppressive cytokines like IL-10, IL-35, TGF-beta. They also kill the conventional T cells by the perforin granzyme. They also downregulate the CD86 pathway and interfere with the CTLA4. So they keep harmonization of the cells and so that your immunity does not happen. So what is the evolution is this ex vivo T cell depletion, taking all this immunological knowledge. The pre-immune experience in the 1980s where the sertraline and there was success in the immunodeficiency children, but not with the leukemia. Till Stephen Meltani in late 80s started doing these procedures, and he came up with these machines which are still working and improving the outcomes. maths and prodigy. So roughly the maths technology, it will do either a direct leveling or indirect leveling in magnetic bits. So you can select out the cells you want, or you can leave the cells you want to be in the procedure. Remember, this here alpha beta is an indirect leveling. So you have the biotin molecule which will bind to the T cell alpha beta cells, and then you have an antibiotic immunogenic beat that will take out the cells. So you have a positive selection, you can just select the CD34 positive cells, or you have the negative selections, you can just remove the CD3, T cell alpha beta, CD19, whatever array, whatever you want to remove. And these processes are very, very accurate. And this is the evolution of T cell depletion, very nice article by Yair Reisner. You had the mega dose CD34 selection, so that was my initial experience in the UK doing the CD34 selected stem cell transplant. Then you moved on to the early 2000 to the 3 and 19 negative depletions by Peter Lang. And then Peter's approach completely changed the way we think. But then we realized that 1619 had a major problem with immune reconstitution. So we had to design better drugs for better immune reconstitution. So what happened? In 2014, Franco Locatelli published this 21 patient data on alpha beta and CD19 depletion. And actually, based on that, the first alpha beta depletion transplant I did was in Singapore in 2014. And then CD45 depletion was published very lately in 2016, but those are mainly in the leukemia patients. So question is, can we combine these two? So currently these are the ex vivo T cell depletion techniques you have. You have CD34 selection, which will have only stem cells. CD3 depletion is getting outdated now. You have left stem cells and NK cells. Alpha beta depletion has become much more popular because after the depletion, you left the stem cells, NK cells, T regulatory cells, dendritic cells, gamma delta T cells. 45R depletion will keep you, give you the CD45R memory T cells. So all these will reduce GVHT to very low level. You're pretty confident you'll not have any GVHT. But they also provide that bottom three will provide you some GVL or anti-infective property. You can now also select as NK and T regulatory cells. This is also possible. So what are the current results of T cell depleted HSCT in benign diseases? I'm going to mention a couple of papers. This is from the Italian Franco Locatelli's group, 70 patient data on all non-malignant disorders. So they have a very high overall survival, and TRN, if you see, are very, very low. But there's a problem. If you have a high risk group like the sickle cell thalassemia, severe aplastic anemia, they have 55% graft failure rate. So that is a problem you need to be aware and address. And the Newcastle group, who are pioneers in the primary immune deficiency, they have now shown that of all the T cell depletion platforms, they see alpha beta and CD19 depletion did fantastically well. And with a very high overall survival, event-free survival rates. And they have now moved on and they have added some memory T cells with this platform. I'm going to show you some results of the Apollo experience. So my experience on the T cell depleted transplants since I came back 2.5 years ago from Singapore. So again, what are the challenges in India if you want to do this? First is the cost. Upfront cost of these procedures are very high, so that will outright be the biggest challenges. And then second is the graft rejection. I cannot have a 55% graft rejection. Use one graft rejection, that's it. And to tell you the story, the first transplant I did for severe aplastic anemia had a graft rejection on the kidney. So we have only one chance. And a later severe acute and chronic GVHT is extremely difficult to manage because you cannot have challenges on a chronic GVHT or grade 3 for acute GVHT is the problem. Multi-drug resistant bacterial sepsis we have never faced abroad is a very big problem, have a high TRN. And viral activations, you have to difficult to identify and monitor them so accurately and manage. So the protocol should have low rejection, low GVHT, low TRM, low infections, and have to be affordable. So it's a big challenge. So whatever I say, mostly the transfusion-dependent thalassaemias have been transplanting. And I'll just show you the outline. About 4 months before the transplant, we do a baseline consultation and assessment, starting on hydroxyurea and adequate ventilation, because many of them are from abroad and actually coming from Vietnam, to be honest, and they are poorly related, poorly transfused. So then we come back again about a couple of months before transplant, have a central line and have a transfusion and IV destruction if necessary, if there are no bloated, and one cycle of PTIS and 2 cycle of PTIS, and during the second cycle of PTIS, we do the TLI planning if they are getting irritation and all the pre-transplant workup. And this is the pre-transplant immune suppression based on Dr. Surabhi Chonte's protocol of PTIS, everybody using this about a week to 4 weeks interval fludarabine dexamethasone. And the donor selection algorithm, of course, the first one is BSA negative donor. But then I'm trying to choose a younger donor. So if there's a sibling who's more than 10, who is haplomatch, I'll choose that one. And then the father donors are preferred because of the access of easier access of peripheral blood center collection. And CME serology are not so important. And this is the what has haploidy protocol we use. Bottom is the day 10. These are the dates. And this is the timeline, and this is what we use. So children less than 3 years of age, we decided not to give any radiation. We just give ATG. More than 3, we give one shot total lymphoid irradiation. And then demands 7 and 6 is cyclophosphamide, and then fludarabine triosulfan. Demands 2 is fludarabine thiazide, and rituximab on demands 1. And the haplo-BBSE gets collected in our hospital and then gets shipped to Delhi for overnight depletion, and then come back to us. And using the same 85-90% for after depletion and 10 to 15 for 45 RA depletion. And we give fresh infusion. I try to give more than 20 million per kg, as I said before, alpha beta or X less than 25 kg, and with fresh infusion with 2 million per kg of memory T-cell. And then we treat some frozen DLI 1 to 4 million per kg for use for viral reactivations or mixed clamsome if possible. Last year and a bit, 20 children had this sort of transplant for thalassemia. We did the data collection on the clinical characteristics, graft composition, engraftment, and that's what I'm going to show you. About median age was 5 to 10, equal male and female. More in E-beta thalassemia, the 14, and the beta major was 6. Now I'm going to show you the class distribution. Compared to Pexaro, we use a NF08 being influenced by Professor Wing Leong. We use this NF08 non-found 08. It's something similar based on the ferritin and mammalian age. And class 3 will mean high ferritin, big mammalian older. So 5 were class 3, the rest were class 1 and 2. And transfusion, median was 45, range was 110. Pre-transplant ferritin was still high despite whatever manipulation we've done, 2000. 3 of them had DSA positivity, but MSA were lower, not less than 5,000 MFI. So clinical characteristics, as I said, after using the protocol, the engraftment is very fast. Median of neutrophil is 11, and for platelet is 13 days. And skin GVHD, initial few variations had some skin GVHD grade 1 to 3, but we were all abortive, and 2 had probably lower GI GVHD and didn't do a scope, but they both responded to short course steroids. None of them luckily had any MDR sepsis or invasive fungal infection, and duration of hospitalization is median 25 days. So currently the discharge days was 12 to 13 post-transplant they were home. And this is probably the most important part of the slide. So if you look at in the bottom, we put the graph proposition. And so the blue one starts, and if we focus on the patient number 11, the blue one is CD34. The saffron will be your CD3. This one will be the gamma delta. This will be the NK, and this will be the NKT. So if you focus on the 11th patient, given the maximum CD3, 47 million per kg, where your CD3 was 31 million, and entirely was gamma delta. NK cells also was very high, 102 million per kg, and NKT of 20 million per kg. So I'm able to infuse a very high number of CD34 cells with high number of gamma delta 40 million per kg, NK 69 million per kg, NKT of 19 million per kg. So what has happened because of very high CD34 cell dose infused, I'm able to give high dose of universal immune cells. So these are not GVHD causing cells. And the TCR alpha beta cells are actually really negligible. If you look at the chimerism, so these are from patient 1 to 19. I have not updated the list, and chimerism from 40 plus 30, 60, 90, 120. So initial patients, of course, had more, and then some data on the long term. So all of them are full donor chimerism, except this one patient who had 97.8 percentage, and the mother got worried, why is my child not 100% donor chimerism? But it remained full donor chimerism. And if you look at the immune cell subsets, on the left is the CD8 subsets, and the right is the CD4 subsets. So day 30, 60, and 90. Entire on the CD8 population, mostly a central membrane effector memory. And only at day 90, we're having some 90 cells on the CD8 subsets. CD4 is the same story. Entire day 30 and 60 are central memory effector memory. Only at day 90, some 90 cells are coming. But remember, these are not the cells providing your anti-infective properties. The gamma delta and NK cells, which are not put here, are the predominant cells in the 30 and 9 and 30 and 60. Even at 90, they are proven to be the major immune protective cells. So early reconstitution of both CD4 and CD8 central memory effector memory cells, major immune protection is provided by the gamma delta and NK cells. Some practical tips and pitfalls. Now, these are learned through my work in Singapore, so I'm not making those mistakes. How do you ensure that enough stem cells? Because I have the only chance of only one apheresis, one production. So, just certain cell limits are very important. So, you have to, when the patient donor is being harvested, you look at the TNC. The TNC, it cannot be more than 60 billion because then the alpha beta depletion will not work. The alpha beta cells in the product should be less than 24 billion. Otherwise, it's not going to work. In the past, it has happened. The technician did not realize, and then put more TNC or more alpha beta, and that product did not work, and then you have to give a PT. So this happened in Singapore. See that recovery in the alpha beta product is close, should be close to 90%, and the depletion should be more than 4 logs. Again, this was a learning process from my initial days in Singapore. Depletion was not that great. When you do a 45R depletion, your 45R recovery is not as good as C34 recovery. It's about 30 to 40%. And this is a paper published from Singapore's group, only came in this year. They looked at the process of 91 patients who had alpha beta 45RA, and they looked at the log depletion. Alpha beta log depletion was 4.3 log, and 45RA depletion was extremely, it's a very potent antibody, so the depletion would be really very good for 4.8 log depletion. So just a practical example, see that a child who had a 30 kg and a mother who is a donor, 69 kg. Mother mobilized with GCSF, always day 4 CD34 count, it was 23 cells per microliter. The question is, would you go ahead and harvest on day 5? Conventional teaching, more than 20 cells per microliter you harvest. But the problem is that if you have a CD34 or 20 cells per microliter, when you do full harvest, it will give you 2 million per kg of the donor. So if you convert that into child's weight, it will be roughly 4.5 million per kg of the recipient. Now, that will be good for a autologous transplant, that will not be good for allogeneic transplant. So this is how we calculate. So of course, we give direct support and increases the CD34 by about 4-fold. So we ended up giving CD34 19 million per kg while the alpha beta was very low. So this is how we have to be absolutely clear that we are going to get enough, and direct support is very cheap here. So we can give it whatever is necessary, and to ensure a very high number of CD34 cells. Now, what is going to be the future of the graft engineered stem cell transplant? This is published by Professor Wing Yong while he is in Hong Kong. It's something I want to explore. Remember, the CD60L is expressed on the nile and the central memory T cell. So if you remove those, your GVT potential should be very low because you're left with the TEMRA and the effective memory T cell. So they only had 7 patients In one of them, the procedure did not work. Other 6 patients was published. So this is, and they showed that it does not affect engraftment and probably it reduces the GVHT and provide protection against infection. So this is something we're looking for. And in future, this is a publication from 11 years ago, and I like it because it says that you should be able to just design a graft. So you should be able to have a haplo donor or any donor. You take enough CD34 cells, you provide enough gamma delta T cells and NK cells, and provide some conventional T cells, and you provide some antigen-presenting cells and some T regulatory cells, and design a cocktail of a graft. So that will have no GVHD potential, but at the same time it will give you the GVL or anti-infective property. So we are looking for the rise of the haplo as a quest for a perfect graft. So starting from the initial days of CD34 selection, it was really awful. Results were there by 60% death due to usually infection-related problem. Now we are gradually coming up and understanding from the basic pathology, physiology, and so we're looking for a perfect graft in future. So to summarize, as I said, advantages of infectious T cell depletion is that every child will have donor. So parents are my siblings or even relatives, and donor is readily available, highly motivated. You can go to a transplant at a very quick number. We should be able to do the NK cell mismatch by the different models we have and use that to our advantage and reduce the risk of graft rejection by these graft facilitating cells. So I had no rejections in so far touched in the thalassemia patients which have a very high risk of graft rejection. And what is important is a very ultra short GVHD prophylaxis. I just give for about 3 months for thalassemia for 1 month, and so it facilitated very fast engraftment. My day 10, 11, 12, the neutrophil engrafted, and the neutrophil is very short, so they're not developing major bacterial fungal infections. And then very quick immune reconstitution. So while we have patients, I have not presented the data. And since the advent of letermovir, where CMV has ceased to be a problem, adenovirus may be a little problem, but not a major problem. And biggest advantage, I think, is the discovery. This is for GVHD because of the selective T cell depletion. And as I said, immune reconstitution with the memory T cell depletion. What I feel is the challenges in the HSA trade are actually for TRM, mostly infection related, graft rejection, GVHD, and if you talk about leukemias, the relapse. So TRM, if you have a reduced toxicity conditioning, rapid engraftment, and early NK and memory reconstitution, the infection is less. Graft rejection, of course, is a problem with T cell depletion, but I think it's going to be less of a problem even with the reduced toxicity conditioning. And the graft facility cells, remember, they're very important. The NK, gamma delta, they have GVHD. I think there's a great disadvantage of ex vivo T cell depletion that you have reduced something you can control. You're controlling by giving, removing the GVHD causing cells. And even if with memory T cell, we know it causes GVHD, it should get aborted. It means in short course of steroid, then you should abort it. Relapse I'm not talking about because we're talking about benign clinical conditions. So these are my acknowledgements, the Apollo pediatric team. In the middle is Shivashish Pal, who is pro in using AI, so he's put this all into ChatGPT and made all the slides, all the graphs and things. And I must say thank to before I left Singapore, this is Ricky from Miltony, and this is Nedul, who does all the depletions. And I did not realize this is possible in India, but they have made it possible by a human courier, so that even sitting in Calcutta, I can do this all the T cell depletion with the accuracy of Singapore, efficiency of Singapore, and in the same time. So they get transported, shipped back, and I can infuse it the next day in the afternoon. And I thank my Apollo hematology team and the blood bank. Was been the pillars of how these procedures are done. Lastly, 2 people I have to acknowledge. Professor Wing Leong from this one special delivery KK local journal. We used the memory T cell, and that's how the journey started. How we added the memory T cell. And Rupert Hangrick, I never worked with him, but remotely has always helped me for my first T cell deletion in 2013. So I'll finish and take any questions. I'm not sure whether I've run over the time. Thank you.
Thank you so much, Dr. Bhattacharya. Any questions, anyone?
Hello, sir. Good morning, sir. Sir, I'm Yashpal.
Yeah.
Basically, I'm running a GMP center here in cell processing facility in Delhi. So I have also worked with Nedon so many times and process of T cell depletion 300, 400 procedures. So my question is this, as you said in your presentation, the cost is the major issue. So cost is the major issue because there was only the one player who was doing all this. Now the technology has coming up and competitors also coming up, as you know, I hope GenScript also has come up in the market and they are also giving a similar technology in almost, I think, half of the price. And I think people need to give the opportunity like you or any other people, not to only one person who is doing and doing everything like last 15 years. I think there are 2, 3, 4 centers is also coming up in India and who is able to do T cell depletion and all your craft and manipulations, NK and other things as well. So means I'm saying my concern basically the cost rate is basically made up by intentionally that cost is very high. It's a 12 lakh or 14 lakh. It is not from the military side. People knows it. But now I think it is a time to make it reduced as another competitor is also there. As I have done 5 patient study with one of the doctor here in Delhi on GenScript and 99% similar results with the military. So its opportunities there. So that's all I just want to say. It's,
Very, very good. I mean, of course, we'll talk after that. What I just mentioned to you, my initial days, even in Singapore, even in military support, there were mistakes done in the. So I'm very aware, cognizant of the fact that that expertise has to be very good, because if the technician is not confident about the depletion, simple things. It has happened to me. The new technician was trying to do the alpha beta depletion, did not realize that the alpha beta numbers were more than 24 billion, and put the entire reagent and the depletion was done with no a huge number of alpha beta cells. So we had to use PTCY. And how do you convince the parents that okay, you spend so much money, but your depletion is not working? So cost-wise, yes, upfront cost is high, but I think we will look at short hospitalization and less bioelectrician, less GBT. Italians, the insurance companies have been told, they now approve it. And even that, because the overall cost to the hospital is actually less. And even in Stanford, I know, speaking to the Stanford guys, they are now showing that their hospitalization duration is less. So I think it's something which is going to take off. We have to look at, of course, more options will be better for us. Yeah. Thank you. Vikas.
So Dr. Fantastic talk as always. Just a concern which we face when we do a TCR alpha beta depletion for our patients. So we started doing TCR alpha beta depletion, I think almost a decade back, 10 years back, when I came back to 2014. We were doing alpha beta depletion left and right at that time. Somehow, quite a number of our patients had, when they were engrafting, had cytokine storm and they rejected. And that brought me back to PTCY. I'm not very sure what was the probable reason. Now we are doing PCR alpha beta, but for specific indications. So in our center we do for pancreas and for TIDs. But for malignancies, for TALs, for sicklers, we do a PTCY based. I'm not very sure. I discussed with you as well. Why are we unlucky? Are we doing something wrong? Why are we facing a cytokine storm, a bad storm, high fevers suddenly rejecting the graft? So any take on that?
Yeah, so the first time I learned was in Singapore, severe aplastic anemia. I think there's one group I'm concerned, and the people across are concerned that your alpha beta depletion may not be the best. And the similar, the first severe aplastic anemia in Singapore, which just started with graft and then had a cytokine storm and rejected. So I think something maybe with the condition. The similar thing happened to my first transplant back in Calcutta. The patient rejected. So severe aplastic anemia is a group. Thalassemia supposedly should be the most difficult ones too, but I am not seeing problems at the moment. There was one MDS leukemia I transplanted the kid engrafted, but then had some sort of GBH which I did not understand. So watch the space, I will say. I have no experience in PTCY, almost no, so I'm trying to just modify my protocol and and see how it works. But I think PDCY also is a good thing. I'm a little concerned of the GBHT. We ever take PDCY or more GBHT. So that the one part I can control, I'm controlling and try to improve on the other parts. Thank you.
Thank you so much. And any other questions, anyone? No? Okay, thank you so much, sir. So next we move on to a panel discussion on the two slides of the sheet, pre and post-transplant challenges. And I would like to call Dr. Gaurav Khare on stage, please. He's a clinical lead and senior consultant at Center for Bone Marrow Transplant and Cellular Therapy in the Basta Apollo Hospital, New Delhi. Can we have you on stage, sir? Is he here?
Yes.
Okay, I would like to call the panelists as well on the stage, Dr. Silki Jain, Dr. Anjali Yadav, Dr. Rohit Kapoor, and Dr. Chandrika Verma. Can we have a round of applause? It's early morning. Everyone is caffeinated.
कौन सा करूं टिल्ट अभी
Good morning, everyone. Good morning, everyone. Thank you, Vikas, for bringing all of us together once again for this wonderful meeting, concept-based or theme-based meeting with HEMENEXT. So the scientific field is sort of very, very pertinent, covering all the burning aspects of hematology in today's day and age. So I was asked to discuss one very important topic, especially in Indian context, which is the transplant-related challenges, especially for hemoglobinopathies. We know hemoglobinopathy transplants are our biggest burden. I would say our bread and butter as well. Rajat has beautifully highlighted the way we do transplants, especially for thalassemia, alternate donor transplants. But yes, that comes with a lot of challenges, and I'm sure Rajat would have realized the patient profile, different patient profile in India as compared to what he used to see in Singapore. And he might be learning his ways to modify strategies to optimize the outcomes. So the two sides of sheet, pre and post transplant care in hemoglobinopathies, and along with me, we have a fantastic team of panelists here. Silki, Anjali, Rohit and Chandrika. So it's a close group. We all know each other pretty well. So why do we need to talk about transplants for thalassemia and sickle cell disease? We all know it's still a huge burden across the globe, and these two disorders, red cell disorders, form the largest burden of red cell disorders across the globe. If we put together the numbers, every year approximately 400,000 kids are born with thalassemia and sickle cell disease, around 300,000 with 300 to 400,000 with sickle cell disease, and there are 60 to 70,000 with thalassemia across the globe. So huge burden. When we talk about the clinical burden, needless to say, both these diseases comes with a huge clinical burden, which is even more in sort of resource-limited countries, not only in India but across the globe. So burden of sickle cell disease, we know, depending on the pathophysiology, which one is predominant, whether it is hemolytic manifestations which are predominant or vaso-occlusive manifestations which are predominant. The clinical symptomatology might differ quite a number of times. It is sort of a mixture of both of them in sickle cell disease. Current therapeutic approaches, so these are the therapeutic approaches for sickle, for thalassemia, and when we talk about the curative approaches, awaiting a largest, wider application of gene therapy, especially in resource-limited settings, transplants remain the remains the only possible curative option for both these diseases. So awaiting gene therapy, transplant is the only curative option for thalassemia and sickle cell disease. Although conventional myeloablative regimens with CNI-based GDG prophylaxis in HLA-inhibited donor transplants, whether it is sibling or related or unrelated, have shown good outcomes, and they are associated with increased risk of regimen-related toxicity, increased risk of graft failure, especially when associated with bone marrow. So that is the reason why a number of our colleagues across the country have moved from bone marrow to peripheral blood. However, certain subsets still prefer, but that becomes a challenge because in sibling donor you can still opt for a marrow, but in unrelated donor transplants, which is increasing day by day, the bone marrow as a source becomes a challenge to procure. So we have to fall back on peripheral blood as the source, and with that, it increases the risk of graft versus host disease, both acute and chronic. So that also needs to be encapsulated in your overall transplant strategies when you are planning it. And in haploidentical transplants, these regimens are sort of, when we talk about sickle cell disease, reduced intensity, and in thalassemia also, we have moved from typical myeloablative to reduced toxicity conditioning regimens. Now, when we talk about India, so basically, we all know that we deal with a different patient profile, both for thalassemia and sickle cell disease. There are some obvious reasons which are there, so improper transfusion practices, suboptimal transfusions, so poor collation. So CK, would you like to highlight, I mean, in your day-to-day practice, what are the challenges and how do you sort of put them in context when you're trying to analyze your child for transplant or preparing that child for transplant?
So, as you have rightly pointed out in this slide, so improper transfusion practices, we often see that patients directly present in the transplant center when they are often more than 10 years of age and they have already been exposed to suboptimal transfusions, like most of them would receive leukodepleted blood, and most of the centers would not have the facility of extended RBC typing as well. So this leads to very high risk of LO immunization in our patients, which makes PTIS a very important modality of as a pre-transplant strategy to optimize the outcomes. And also the poor chelation, as you said, because iron overload, it leads to end organ damage, and this increases the chances of rejection of GVHD and of VOD as well. So does compromise the outcomes post-transplant.
So actually, so anything which you people do differently to address these challenges?
Actually, in India, I have seen that 2-3 patients, the labs are not standardized. So in lab, I have seen 2-3 patients in which the DSA was positive, negative from the other labs, but positive in our lab. So I think normally we recommend lab lab or any standardized lab for the DSA, right? And in case you will not do that, then I would say that we do some desensitization or one cycle of plasma pheresis to IPIG because the allogenization has that effect.
Right. So when we talk about this DSA, I mean, yes, you rightly pointed out, I mean, it has to be done very, very carefully. So a better way to do it is when you do it in a combination with sort of PRA, which is sort of initial screening, but when you club your PRA with your DSA, that gives you sort of overall better analysis. And always good, rather than initially I used to just throw the ball in lab's code that, okay, this is the HLA, please give us a report which is easy for me to read. So they specifically say that, okay, the DSA is positive against this donor and this is the MFI. But of late, what I have realized is I just don't get the HLA report. We just get the overall analysis and then try to work on it on our own. And that gives us a sort of a better idea of what is the DSA status. Now, moving further, so anything which you'd like to add there, Chandrika or Rohit?
Sir, actually, currently, you said that there are donor-specific antibodies, and actually, we need to know the MFIs actually. So, if it is less than 2,000, then we are in a good state. With 2 to 5, we need some help. We need some IVIG, Plex, Bortezomib. The best agent is daratumumab, which is like one of the if money is an issue, one shot dara 8 mg per kg, just distill step once, we are good. Okay. Other than that, IVIG should be in the conditioning, like intercalated between the conditioning. Okay, plasma exchange should be near to the conditioning, near the proximal portion of the conditioning, so that we remove the antibody the fastest. Okay, so if other than the DSAs, there are 4 to 5 catches that I wanted to tell. There is C1Q and C3 DSA. Okay, and there is flow cross match. The three other things other than the DSAs that we always focus on, that okay, we have DSAs, we have lots of antibodies, rejection would be there. But if first we can if the titer is more than 2,000 to 5,000, we can desensitize, but we can recheck the DSAs. They may or may not go down, but we can do a flow cross match. We can do C3D, C1D, C3 DSA and C1Q assay or flow cross match to make sure that we can use that donor to so that we can ensure that there can be engraftment and for medical legal purpose as well. This is the thing. And the key thing is that sometimes I have observed in thalassemia patients who have been given a lot of transfusions and a lot of RBC sensitization has happened. So in these, sometimes prozone phenomenon can be there. So the prozone is like these spurious MFIs are there, but they are spuriously low. But in fact, they are high. You're gonna do a complement test and then you do flow cross to make sure that I have only one test donor. Then it will be the best. We are also safe and we are also confident that we can go ahead with the condition, because the money is also an issue.
So I mean, yes, it's not as DSA assessment is not as simple. Its role and its use and importance in hepatotic donor transplant is pretty well said. So I think the standard algorithm is PRA followed by your DSA, and if DSA turns out to be positive, then you have to assess that whether those antibodies which are there, they are actually capable of causing damage. So that is where this even QSPS assessment comes in picture, where you look at the efficiency, complement binding efficiency of these antibodies, and thus the increased risk of harming the incoming stem cells. So that's the standard algorithm which needs to be followed. Now, so if you look at how to address these challenges in sort of especially Indian context. So there's a fair need to suppress the hyperactive H5 compartment. So what happens is with poor, what we have very commonly seen is that our patients are usually kept at a hemoglobin of around 7 to 8 because the practitioners looking after them, they have this perception that hemoglobin, the blood will only be transfused when the hemoglobin will fall below 7, which is the general consensus, but they need to be made, understand that for thalassemia it is different and the transfusion threshold has to be kept more than 9.5, but unfortunately that is not followed in many centers, and that is what leads to this hyperactive H5 compartment which needs to be addressed, and as highlighted beautifully by Silky, that PTI is pre-transplant immune, and I say pre-transplant immune and myeloid suppression is a beautiful strategy. Then there's a need to reduce regimen-related toxicity. These patients have, both for thalassemia and sickle, they have some bit of organ damage, either due to increased iron overload or in sickle cell disease per se, because of the disease-related complications they have endowed damage, and that is why there is a need to shift from myeloablative to reduced toxicity conditioning. Then there is a need to reduce graft failure and faster engraftment. PBSC, most of the people have now moved from bone marrow to peripheral blood. And when we talk about peripheral blood, there is also the conventional mobilization is GCSF based, but now people have started clubbing GCSF mobilization with plexical mobilization, because this gives an edge. It preferentially mobilizes CD34 cells and limits the CD3 exposure to some extent, so especially in alternative donor transplant, this becomes a very, very important strategy. Now, to reduce the risk of GVHD, so when we move from bone marrow to peripheral blood, the conventional teaching is that for thalassemia and sickle cell disease, the preferred source is bone marrow, which we all agree. But keeping in mind all the challenges which we have seen in the past, and the feasibility of peripheral blood and the need of peripheral blood, especially in alternate donors, whether it is mud or haploidentical transplants, most of the people have now moved to peripheral blood. But with peripheral blood comes a lot of challenges of acute GVHD and chronic GVHD. So for this, PTCY has come in beautifully. TCD, Rajat has already highlighted the role of TCD, but majority of people still use PTCY in our Indian settings. And there's a need to reduce CNI related complications. So we know that CNIs are increases the risk of endothelial complications, especially thalassemia and sickle cell disease, where per se the risk of endothelial complications, whether it is VOD or it is PRES or any other complication, is more. So CNI, so some groups have tried to move from CNI-based GVHD prophylaxis to mTOR-based GVHD prophylaxis. So these are the challenges which are there both in thalassemia and sickle cell disease, and we have also seen. So the overall objective here is to achieve a state of immune tolerance between the donor cells and recipient cells, and this is especially more relevant in sickle cell disease. In thalassemia, you need to have a graft which is more than sort of 95%, but for sickle cell disease, if you still have a mixed donor chimerism, it is fairly okay to give a long-term sort of disease-free period. Now we'll move to cases because these are the scenarios which we very, very commonly encounter, and they are not that easy to sort of figure out and to make a plan. So this is the first child. These are all these patients are sort of real world challenges, patients who have presented to us. So 15-year-old boy, transfusion-dependent thalassemia, improper transfusions as usual. Ferritin is close to around 3000. T2 star MRI which we did shows a moderate liver iron concentration, and cardiac iron concentration is within normal limit. Now this child has a mad sibling donor, okay, using a sister who's like 6 years old. So how will you plan transplant for this particular child? What will be the things which you will keep in mind pre-transplant? Silky.
Thank you for the question, sir. So, a 15-year-old boy, the age doesn't seem to be very optimal because we say that 3 to 6 years is the optimal age for thalassemia transplant for the outcomes to be the best. But fortunately, this patient has got a mad sibling donor, and we know that the outcomes are best with the mad sibling donor as compared to mud or haplo. So this transplant seems to be favorable, but apart from the donor consideration, we need to look at the age of the patient and the iron overload status. Very, very important to look at it before we are planning the transplant. So this patient seems to be, if we have to classify according to this arrow classification or correct, so seems to be class 3, which is not a very good thing for this patient. So we really do need to optimize the chelation status and bring down the ferritin to at least, I would say less than 1500 if possible, by optimizing the chelation strategy. So if the patient is only on single agent like deferazolox, then we can add this furosemide IV 5 days a week, so that we can achieve ferritin of less than 1500. Then the other thing is that we should use PPIs in this situation, because although there would be conflicting opinion, I think, in the house, because we are dealing with a mad sibling donor here. And since the patient seems to be class 3, he has moderate liver iron overload. And there was a publication from Team CMC Vellore in 2007 where they had shown that among class 3 patients also there is a subgroup wherein patients more than 7 years of age and with hepatomegaly of more than 5 centimeters, they do significantly poorly as compared to the other class 3 patients with a survival of, I think, they showed only 30% post-transplant, even in maxillary scenario. So I personally would prefer giving PPIs to this patient, if not 2 cycles, maybe 1. And the other thing is, because the patient is 15-year-old, so we need to work up the patient for endocrine dysfunction, which is very, very likely at this age because of iron overload and target end organ damage. We need to work up for it, and we also need to counsel the family about, give them the option of testicular, of sperm cryopreservation. In post-pubertal, we do sperm cryopreservation, and in pubertal, we do testicular tissue cryopreservation, and give them as an option.
I think, yeah, the very well covered aspect. So, I think iron status, as you rightly said, is the key to the success of transplant. These are all elected transplants, so there's no hurry, unlike aplastic anemia or leukemia. So rather than 15 years, even if you take 6 more months and plan the patient better, it's not going to cause any harm. So you should give fair amount of time to sort of reduce the iron overload, and optimizing your chelation strategies is a very appropriate strategy. So people have used dual chelation and also triple chelation under close monitoring to actually bring down the iron overload in the expected range. Secondly, fertility is very important. I think this is something which now, as transplant physicians, when we have optimized our transplant strategies, we need to move beyond our routine outcomes and look for long-term actually quality of life. And from those aspects, fertility preservation and the strategies around that become very, very important. So for this child, you have very rightly mentioned, Silky, that's a very important thing to do. So, and when we talk about giving an option, I look at it in a different way. It's not about giving an option, it's about counseling them in a way that the transplant objective here is not just to make him transfusion free, but to improve the overall quality of life. So it should be guided in a way that they opt for it. So sperm preservation, provided it possible. I understand that testicular preservation is not that easy, but sperm preservation at this age will be a feasible approach, and we need to give him sufficient time, because with kids it's not that easy. So you need to give them 2-3 sessions so that we can get desired number of sperms to be preserved. PTIS is a debatable thing, but I'm a strong believer along with my other colleagues that yes, it is a strategy which doesn't cause any harm, but comes in with a lot of benefits. So that has to be placed with a 1 cycle or 2 cycle, or some people in analytic settings do even 3 cycles. We'll talk about the agents, what agents do individually people use. But moving on to the next thing, so what will be the conditioning chemotherapy in this particular child actually?
So, sir, mainly because Sikhi mentioned this child is a high risk child, and we normally prefer to condition as one is suicide, and other is TTF. So, because this child is a high risk child, I would like to give the TTF condition because child is having a weakest proper transfusion and also having a moderate liver load. So, the risk of leak is very high in this child, and yourself is better on that. So, we'll do. And one recent study also showed that fertility preservation is better with TDF as compared to suicide. So, I will keep the TDF regime. And regarding the chemotherapy, it is very important because T cell rejection is very common in these high-risk patients. So, I would give the ATG, and we normally prefer Gravinon in this. And in high-risk,
so using ATLG, even in sibling donors, and so that's really good. Okay. Okay, so that is it. So one thing I would like to ask, not only from Anjali, but from every, so when you have a choice between BUSI and TTA, so even if say you have a child 7-year-old or 8-year-old, would you still prefer a BUSI, and if the child is sort of maybe class 2, maybe class 2, or if there is an option, you would prefer?
we counsel normally the parents about the benefits of the TTF and BUSI, and if the cost allow, then definitely
So the preferred choice, keeping aside the cost, is TTF. And I think Silky just posted, there's a beautiful publication from Dr. Reddy's group, which has come recently, just 2-3 days back, which highlights the long-term importance of fertility, preservation of fertility, especially with TTF regimen. So I think there's no question that TTF is a better regimen now as compared to BUSAI. As far as the cost is concerned, I think the companies are sort of noticing that it is an important strategy, and they are trying to come up with alternatives which are sort of low cost alternatives. And especially for Thyteca, we have seen that change, and I'm sure with Triosulfan also we have sort of low cost alternatives which will serve our purpose.
So the long-term cost anyways comes out to be the same.
Yeah, I think if you land up in sort of one complication with BOD, one transplants actually compensate for the cost of additional cost of 5, 6, 7 transplants. So yes, you are very right in that. Now coming to sources of stem cells and what would you prefer, bone marrow or peripheral blood? Why, and pros and cons of both of them?
So actually, if we go with the guidelines, the best is the bone marrow. Okay, so CIB and PR guidelines always say that the bone marrow is the best. Now what is going on? We have peripheral blood as well as bone marrow. We have the two options. It's a non-malignant condition, and we do not want graft versus leukemia effect. So best would be the bone marrow. But bone marrow, the patient has to be put in the OT. The patient has to give an anesthesia. Now we have to do an aspirate. Both will, the two person will do an aspirate. Blood bank will be involved a lot. Some lots and lots of processing would have to be done. Stem cell enrichment would have to be done. Now the cost of now issue comes of the cost. In India, the main thing is we have to do cost cutting. As simple as that, because of the cost issues, we have to go for peripheral stem cell harvest. Now, okay, we got the peripheral stem cells. We have lots and lots of CD4 helper, and we have cytotoxic and TH17 cells in the peripheral blood. We do not want those that much. So main issue comes out to be the T cells that will get lots of T cells from the peripheral blood that would create an acute and chronic GVHD related issue, which is less in the bone marrow and which is more in the peripheral blood. So the key is we have to balance the cost, number one, and we have to balance the acute and chronic GVHD. Bone marrow always has an advantage. We have, but the engraftment is an issue. It comes up.
How do you practice it yourself?
So it is always peripheral blood, and because it is cheap, that is the main thing.
So I would debate that. I mean, it's not about the cost. More or less, the cost turns out to be the same because the cost of engaging OT and the cost of the kit is like it turns out to be the same. So we haven't seen a major difference. So there might be a cost difference of 5-10%. I think this is a fairly well accepted thing that some people still stick to bone marrow, whereas other centers have moved to peripheral blood. And I think it's more of a institutional sort of or a center-based approach, and that center-based approach is based on their previous experiences. I think rather than venturing into anything different, they should just stick to that particular approach and try to modify their strategy around that. One thing which will be important in this case is that you have a 15-year-old patient who's weighing say roughly around 40-45 kgs, and the donor will be around 12, 13, 14, 15 kgs or maybe 20 kgs. So getting the desired amount of stem cells from bone marrow might be a little bit challenging. So that will be additional sort of point towards using peripheral blood in this source. But I think the point is well taken. Some people still prefer bone marrow as a source. They might add GCSF to the priming to get a little bit better dose of CD34 cells. But yes, both the strategies are well accepted, and I think it is more of institutional policy which people stick to.
Sir, I would like to add something. So, if you are planning to use triosulfan-based conditioning, there is data to show that if you use bone marrow with triosulfan-based conditioning, mixed comparison is more common. So, PBSC works better.
I think yes, but that data mainly is when you haven't used your PTI strategies. But if you use your PTI strategies, I think that data might not be relevant. We do not have literature until we publish it as a group based on our PTI's experience. But that was in patients where there was no pre-transplant planning. They were just taken up for transplant upfront. So there, this difference was well noticed. Now coming to the next strategy, so GVHD prophylaxis, Chandrika, what will be your approach? So we're using both these things, so like if marrow is a source or if blood is a source.
So conventionally, the choice for GVHD prophylaxis has been CNI, cyclosporin, starting from -2 and followed by short course of methotrexate being given in A+1, +3, +6, and +11. This is the standard which has already
Established.
established in all our hospitals. But alternate strategies are being employed more often nowadays, as previously the chemotherapy has also been added. So we can add ATG and can be placed with tacrolimus and MMF with that also. Nowadays, chemotherapy is also there with PTCy even in massive tumors.
I think that's very well taken. So those are the conventional approaches, but yes, as you move towards your sort of different conditioning, different pre-transplant preparation, different bone marrow source, which is like if you are, especially if you are considering peripheral blood, then GVHD prophylaxis, PTCy comes pretty strong to be placed in that particular strategy. Now moving to another child, 10-year-old boy, thalassemia, transfusion-dependent thalassemia. Again, same story, improper transfusions, ferritin is close to around 2800. T2 star MRI, again, moderate liver iron concentration, cardiac iron concentration is normal. Now this child doesn't have a sibling donor, so he's the only child, and we look for unrelated donors, and we got a very good number of unrelated donors. So that's the current scenario. The things have improved over a period of time. I mean, when I used to do a search 10 years back, when I came back from UK, for 100 patients, we used to get donors for 2 patients. Now this has changed significantly. So, I remember around 7-8 months back, we did a camp somewhere. We did HLA for 70 patients. 30 had a sibling donor. Sorry, 18 had a sibling donor, and we got another unrelated donor for another 25 patients. So the things have changed significantly. So fortunately, this child had a few very good unrelated donors. Now, in this particular child, do you consider PTIS as your pre-transplant preparatory strategies? If yes, why and what is the usual choice? I mean, people have used different agents, which we will talk about briefly in the next slide. But what do you use in your practice?
So, sir, 10-year-old boy, again, looks like class 3. Fortunately, patient has a mud donor, and we know that in thalassemia, mad sibling donor results are as good as mud donor, at least according to international literature. So, if about PTIS, so yes, I would like to use PTIS in this case, although the role of PTIS is very well established in haploidentical transplant, the data on mud is also emerging. And if I was trying to hunt in the literature if there are any established, if there is any established data on the role of PTIS in mud, I could not find much, but yes, there are a couple of papers. One was published in 2013 by the Thailand group, wherein they have shown the data on 18 patients, 18 high-risk class 3 patients, out of which 11 patients were either underwent mad sibling donor transplant or mud transplant, wherein they used 2 cycles of flu-dex along with the reduced toxicity conditioning of flu-BU-ATG without cyclophosphamide. So these patients did exceedingly well, and the survival, the long-term survival was around 89%, which is very good. So PTIS does help in mud. There is another publication, very recent one from China, wherein they have reported on 88 patients. All were mud transplants, and then again they have used 2 cycles of PTIS, same fludarabine dexamethasone, and they have shown excellent results, better results, no rejections in this group compared to previous transplants which were done without PTIS. So yes, there is data, and I think, sir, there is a paper from your institute as well.
So yes, my answer is yes, and would use 2 cycles of fludarabate dexamethasone.
Right. So, yeah, I totally agree with you. I mean, PTIS has come in with a lot of advantages, and the actual concept of PTIS is not new. I mean, if you look at Protocol 26, which was developed to cater the high risk thalassemia, so class 3 or high risk class 3 as per Wayne classification. They had significant sort of worse outcomes as compared to class 1, class 2 in the same group, and that is why they moved to Protocol 26 with some modifications where they started preparing patients like 3 months in advance and introduce the hydroxyurea as a therapy, hypertransfusion, and the intent was to reduce the sort of red cell mass in sort of little bit of myelosuppression, and also to some extent because azathioprine was also placed to reduce alloimmunization. So the concept is not new, but yes, people have played with a number of agents, and recently, as you said, Thailand group highlighted the importance of fludarabine and dexamethasone. In India, I think it becomes even more important because of all the challenges which we have in thalassemia patients. The agents used are fludarabine, dexamethasone is the standard. Some people use cyclophosphamide along with it. I've seen that this Thailand Suradej, when I met him recently, they've started using Solitinib now in pre-transplant PTIS. So, and he was very happy with it because the challenges which were there with fludarabine and cyclophosphamide was not they were not there. But I haven't seen the publication, official publication using Luxolid as PTIS. So, do you practice autologous backups in your patients? I mean, this is not a standard. This is mainly sort of India-centric approach.
So ideally it should be done, but in our practice, in low risk, because most of the thalassemia marrow is fibrosed, so it's difficult marrow for harvesting. So in low risk, we not counsel the parents about the autologous backup, but in high risk, again the graft rejection risk is high. We counsel the parents about autologous backup and tell the risk and benefits of these because it increases the cost definitely. So if they are no, in high risk only.
Yeah. No, I agree with you. I think the cost is only when you are discussing. If unfortunately things go wrong, then cost never comes. So the first thing is that we never told you about the cost. Okay, so you did not give us this option. हमने तो पैसे की कभी बात ही नहीं की. So I think yeah, it's always about sort of playing safe because losing a child is the worst thing to happen. If rejection happens, it's okay. It's still acceptable to the family. But losing a child, it's acceptable for the family and acceptable for the transplant team. I mean, we also get so depressed when you lose a child. So saving a child with or without diseases is more important than anything else. So I think this is debatable, but yes, if it is possible, I think for organ donor transplants, we prefer to back up. Now, moving on to the source in this particular smut, we have already touched upon it, Rohit. So, if, briefly, I would just like to ask you that when we talk about mud transplants, to sync between your transplant date and the availability of fresh stem cells from the mud becomes a huge challenge. So, do you practice cryopreservation or you still prefer to collect sort of fresh cells for infusion?
So actually, the cryopreservation is the best thing that we should be doing. The main thing is that most of the stem cells which we are getting, it is like from the international, the DKMS registry or Indian or Dartry registry by by searching various HLAs and we try to search the best donor from wherever possible place where we can at the lowest possible cost. This is the thing. So the thing is the cells have to come from a very long route. The flight delay can be there. There can be, some loss of stem cells during the
There are a
process.
lot of uncertainties.
Uncertainties are there.
To keep
The patient is already got on conditioning.
yeah,
So
he neutralizes those strategies. You prefer
cryopreservation. And we have to keep some set of cells so that we can give DLI with some mixed mechanism.
Sure.
So we need to cryopreserve them, even at our institute.
So that's a very point well taken that cryopreservation, although it has the preference is always to infuse fresh cells, but I think that in our context, to get away with all the uncertainties around transplant, donor difference, which is the biggest challenge that we have seen donors differing after day 3 of GCSF. So keeping all those things in mind, travelization is a very reasonable strategy. Now again, Shamika, so I'll skip this because you've already touched upon this, that because we are using PPSC, when we talk about the GVHD prophylaxis, PTCY will be an important strategy to place in this particular child's sort of GVHD prophylaxis strategy. This is mainly about haploidentical transplant, so I think Rajat has very nicely covered this, so we can skip this particular case. Role of PTIS, strategies and challenges. So again, I think we have discussed it. So it has a well-established place in haploidentical transplants and also mud transplant. And rather, based on the success of PTIS in haploidentical and mud transplants, people are trying to incorporate it into sitting donor transplants as well, just to take your patient to transplant in the best possible shape. Okay. So agents we have already discussed about it. So I think we just skipped. There are certain challenges with PTIS, what you've seen, like CT deactivation, febrile neutropenia, but majority of them are manageable. We have also seen patients with HLH, which are also nicely managed with steroids, followed by Jakavi, which we try to bridge over the initial transplant period. Moving on to sickle cell disease. Sickle cell disease, as we all know, is neglected disease. And transplant is the only possible curative solution for patients who are severely symptomatic and are sort of non-responsive to hydroxyurea. The sooner we do transplant, the better are the outcomes. So this is the first child, 18-year-old girl. She presented. She was from Chhattisgarh, homozygous sickle cell disease, very symptomatic, VOC, stroke. She was on hydroxyurea, but obviously she was not non-responsive or suboptimal response to hydroxyurea. She came to us for BMP consultation. She had a sibling, but he was not a match. So how will you approach this? So what will be the things which you keep in mind, like counsel, how will you counsel, fertility issue we have already touched upon, and stroke recovery counseling, like the damage which has already happened. So how will you approach this particular problem?
So, this is a difficult scenario. Ideally, this patient should have been transplanted much earlier, but whatever the scenario is, with the best possible available donor, this patient needs transplant as soon as possible. And family, I think, must be aware of that of the morbidity that the patient is going through, and that transplant is essential. So they need to be concerned about that the outcome might be suboptimal as compared to if the patient was transplanted earlier. Fertility issues we have already highlighted. It is more of an issue with sickle cell disease because of it is like an endotheliopathy, and it causes direct gonadal damage as well. Per se because of the disease, apart from the iron overload. So yes, fertility issues would be much more in this post-pubertal patient. And again, the oocyte cryopreservation must be done for this patient. And post-BMT stroke recovery, we should counsel the patients that whatever permanent damage has happened will not recover.
Or it might take a little bit longer to recover with extensive rehabilitation. Yeah.
But then the transplant would help in stabilizing the cerebral microvasculature, which is quite compromised at this time.
So very important things, Silky. So I think my lessons learned in such patients is that first of all, you need to be very, very, very careful when you are transplanting them, because there is a sudden change in their sort of hemodynamics pre and post transplant. So rather the post transplant period till day 60 to 90 is even more risky for having intracranial complications as compared to your pre-transplant period where you are well prepared. So they need to be on a good sort of
the platelet count needs to be
more than 30,000. anti-epilepsy prophylaxis. So we usually keep such patients on dual prophylaxis. So those are the strategies. And when it comes to fertility, I think for males it is relatively easy, but for females it is not that easy. We have tried to do oocyte preservation in rather we counsel for all our patients who are eligible, but oocyte preservation unfortunately in sickle is not that easy because we do not the ovarian reserves are pretty compromised. And same is the case with sperm preservation, but we have already seen that the patients who undergo transplant without fertility preservation, when they come to us 5-year post-transplant using TTF regimens, their actually gonadal function is much better, which has been highlighted by Dr. Revaki's group as well. Now, screening, I think again she has highlighted, so we can skip this question. So, extensive organ dysfunction has to be because this is an endotheliopathy. It's just that if CNS is affected, that doesn't mean your other organs won't be affected. So, this child, this patient will be at risk of VOD, will be at risk of other endothelial complications. Donor preferences, might versus haploidentical transplant. So, in context of sickle cell disease, based on the literature available, what will be your choice, might versus haplo?
In case of actually sickle cell disease, we would rather go for half mass donor transplant rather than the mud because the mud would cause like much more later onset complications that can be like more of chronic GVSD. That is the main issues in this condition. And secondly, in the PT side, the PT side has a very good concept behind it that it reduces immune problems. So it would actually in this scenario, in sickle cell disease, we would rather use PTs, the half mass donor here, and we can use PTs post-transplant cyclophosphamide platform to induce immune tolerance, which will later take care of the chronic GVSD-related issues that can arise that are more in the age group of these because it's an elderly, old sickle cell patients.
I think yes, haploidentical donor transplant, based on the literature, the things might change 5 years down the line as the sort of evidence evolves. But based on the work which has been done by the previous, especially Dr. Shalini Shenoy's group has shown that outcomes of mud transplants are inferior, but that was with a different approach. So if we take the approach incorporating PTIs and other things, the things might change in the course of time. But as of now, yes, haploidentical donors are preferred. Role of RC, red cell exchange in this patient?
So in this patient, we have the history of multiple VOC, stroke, RC with red cell exchange will help in stabilizing the already activated endothelium. And as you rightly said, the post-transplant and peri-transplant period is more complicated by the serious complications, so it will help in reducing that kind of complications.
Absolutely. So RC is very important in this child to prevent immediate sort of post-transplant intracranial events. So I think PTS we've already touched upon. Conditioning chemotherapy, just a quick word, Chandrika, you will prefer myeloablative or reduced intensity? We prefer because she's like a significant organ damage is there, so no point. And especially in sickle cell disease, it's very different from thalassemia. As we move, as the age progresses, the bone marrow niche is already compromised. And that's the reason why these patients have more chance of myelodysplasia and other things. So you don't need a myeloablative conditioning chemotherapy for adult sicklers. So that is more of a reason. Even if this child would not have had all these complications, and I would consider this child for transplant, I would still use RAC rather than a myeloablative conditioning. Right. So, second case, 7-year-old boy, homozygous sickle, infrequent VOCs. So not very symptomatic, but has a full match donor. A very sort of debatable question, but what will be your choice? Will you transplant or you will wait?
It's a difficult question.
I think yes, it will depend. It has to be a thorough counseling with the family.
But according to ASTCT guidelines, yes, the guidelines are now advocating for bone marrow transplant in asymptomatic child as well, because the outcomes are better in such scenarios.
Almost success rate is close to 100%. 98, 99, 100% in this age group with a full match donor, and that's why it adds a significant value to quality of life to the child. So that's what is recommended. But I agree with you that it will be a question with a lot of debate, and we are trying to address it in the HCT guidelines which we are working on. So that is it. one more child, I think here you have already highlighted the preference of mud donors, the sort of haploidentical donors over mud donors. So this was the thought behind this particular question. So I think we can skip this. So the carry-home message is transplant for thalassemia and sickle cell disease is more of a standard of care now. Donor options vary from sibling donor to unrelated donor to haploidentical donor. And all of them, the outcomes are improving day by day with modified strategies. The success rate of transplant is improving. Age and disease burden are critical in deciding success of any transplant, whether it's a sibling donor or a blood transplant or haploidentical transplant. And the strategies need optimization to meet the needs of individual patients. It might be different from one patient to other patient, especially in sickle cell disease and also in thalassemia. So every patient is different. So you see a 5-year-old with a class 3 sort of status, and you see 15-year-old who are as good as your class 1. So in thalassemia also very different presentation. So the strategies need to be individualized based on the needs of the patient. So India has huge potential and capability to teach a lot of lessons to the world, especially in hematology transplants. And I think we are heading towards that. Some beautiful work has been done by our colleagues. So Dr. Virti's work today has been published. So lesson to be learned that STTF regimen is good over a period of time. Our colleagues down south, Sunil is doing a fantastic work in thalassemia haplotransplants. And same holds for sickle cell disease. Vikas also published his recent data showing beautiful outcomes of sickle cell disease transplants. So I think we have a lot to offer to the world, and I think we just need to come up together and compile our data and put it together so that whatever we have learned over a period of time can be passed on to our colleagues globally. So thank you very much, Vikas and the entire team for having all of us here.
Thank you so much, sir. Thank you to all the panelists for such an engaging discussion, and thank you, Dr. Gaurav. Next, we have Dr. Ramya Apularu. I think I pronounced it right. I don't know. Okay, so it's a virtual session, and she's going to talk on HSCT in metabolic disorders. So we will have a virtual session with Dr. Ramya.
Switch करियो, switch
Dr. Ramya, can you hear us? Me, please.
Yes. I can hear you. Can you hear me?
Yes, you're audible. You may start the session now.
And you can see my, yes. You can see my slides, right?
Yes.
Okay, thank you so much, and truly apologize sincerely for not being there physically. And I really thank the organizers for giving me this opportunity to be part of this very interesting and focused and important meeting. So I'll just go through a little bit about inborn errors of metabolism, what data is available generally, and what we have learned over 20 years in these children. So the main diseases that I will be covering under the scope of IEM, we know there are several, but the main ones that I will talk about is mucopolysaccharidosis, Gaucher's, X-linked adrenoleukodystrophy, and metachromatic leukodystrophy. And these are generally published guidelines where HSCT is indicated in inborn errors of metabolism. So as we know, these are conditions which are where the children are born without a particular enzyme which is important for normal metabolic activity, simply to put that simply. And the whole idea of transplant works on the idea of cross-correction, where you give the stem cells, the new stem cells, which go to the tissues and organs and then produce new enzymes, which then result in reversal or stopping the progression of further damage to tissues, which happens otherwise due to lack of the production of the enzyme in the child. So this is a lot to learn from these children. A lot has happened over years and decades. And even today, we don't have answers enough, and I think protocols are still being modified at what is the best way forward for these children, which I'll come to in subsequent slides. So the indications where we know HSCT is definitely helps or is indicated include MPS 1, Hurlers, Hunters, metachromatic leukodystrophy, Krabbe's, X-linked adrenoleukodystrophy, Wolman's disease, and a few other rarer ones. Gaucher's is not included in this list because it's It's a little bit different to the usual enzyme deficiencies. The bottom line is any inborn error of metabolism where we know there is a poor neurological outcome, where there is associated neurological deterioration or degeneration, are certainly conditions where you wouldn't want to offer a transplant. So I'll just go through a few cases and we'll go base the discussion on what we've learned from these children. So this is a 1-year-old girl, only child who had MPS 1. She was normal neurologically and had normal hearing and vision. She underwent a matched unrelated donor transplant with a flutriotherapy by ADG regimen. She's now almost 8 years post-transplant. She has complete chimerism, she's growing well, goes to school with no obvious neurological or skeletal effects. And this is a very happy story, but this is not the case all the time. We had 2-year-old twin boys, twins, and a boy and a girl. Both had MPS 1. The twin girl had advanced neurological disease when she came to us, and therefore HSCT was deferred. The twin boy had normal vision, normal hearing, neurological assessment at that point in time was normal, no significant defects. He had a fully matched father. We gave the FPP regimen, and post-transplant he had complete chimerism. However, 6 months post-transplant, he continued to have deterioration of vision progressively, which could be due to multiple reasons. He had GVHD, for which we had to give steroids. It could be related to the underlying condition itself. He had glaucoma with visual impairment, which remained stable for about 6 months. Now he's almost 5 years post-transplant. He's gaining milestones. He's otherwise growing well. However, he doesn't have normal vision. So have we left the family? We don't know, but he's alive but doesn't have vision. So MPS, mucopolysaccharidosis, as we know, have various names, and these are all based on people who discovered each of these MPS. And there are several MPS types, we know, 1 to 9. However, transplant is indicated predominantly in those MPS, which is MPS 1 and 2, where neurological involvement is less. Of course, MPS 6 also can be considered as part of this, where we do not have neurological involvement. So a lot of work has been done in this field from 1980s, where the first transplant for inherited metabolic disorders was performed in a 1-year-old child with Hurlers. Since then, this is very old data, which is like more than 500 transplants have been performed for Hurlers. Now it is way more than that. And age is definitely a factor, we know, because now recently we had a very nice discussion, I think, through the SBCTT itself, and Professor Robin had come and he said, don't fixate on age anymore. In general, look at the neurological status and how the child is. However, just like in HALS, we say age does matter. However, we don't have to fix on that anymore. It's not an absolute contraindication here as well. Earlier, obviously, is the better. If they are less than 2 years of age, the neurological deterioration, the late effects, or the disease status the child comes with is far less as compared to when they are more than 2 years. So therefore, the outcomes are obviously better. And the main reason why this is important is because, as I mentioned, the cross correction. It takes about 6 months for the stem cells, the new stem cells, to settle in the body and to produce the enzyme such that you don't have any further progression or such that you don't have any further deterioration. So up to the first 6 to 8 months post-transplant, there is still a chance of deterioration of vision or deterioration of neurological condition or progression of any of the organ damage, and therefore earlier the better. And we know the UMS and the university, etc., where Dr. Prasad and all work, they do newborn screening and pick up children for these transplants, for several other transplants as well in metabolism. We're not there yet, but earlier the better, obviously. So similarly, in patients who are less than equal to 2 years of age, ERT followed by transplant is what generally the Western world follows. In India, we have issues with obtaining the enzyme replacement therapy. So therefore, going ahead with the transplant right away is the first option for most of us, especially if the child is stable at that point in time. So again, similar data to say that when they've undergone transplants, especially if they have a full donor chimerism, there is a good chance that they can achieve 100% normal enzyme levels. And outcomes can be significantly better in these children. there is, and we have seen good improvement in even organ damages when we've had early transplants in children. So there's improvement in neurocognitive function, improvement in joint integrity, motor development and growth. Corneal clouding has been shown to reverse, especially if we've done early transplants. Cardiac functions tend to improve. Hepatosplenomegaly definitely goes down, and we notice this all the time. And a better, improvement in hearing, visual, auditory processing. And MRI changes as evidenced in children pre and post transplant also. If they've been transplanted early, the enzymes are optimal, have reached optimal levels in the body. The MRI changes also have been shown to improve. However, there is definitely variability of residual disease, and I'll come to this in the last couple of slides. This is something we need to counsel families significantly, properly, and again and again about the fact that there will be some residual disease. And what influences the amount of residual disease is the factor, the comorbidity which they come to you with, the amount of already existing disability when they come to us with. Of course, transplantation early with full chimerism and therefore maintaining normal enzyme levels post-transplant does help in decreasing the residual disease post-transplant. Moving on to some more scenarios in these MPS patients. This is a 1-year-old boy, and then with MPS 1, normal neurology, no matched family or no matched family or untreated. So in our country, we know we do a lot of haplotransplants, and definitely that is an option for these children as well. So in this child, we did 2 cycles of pre-transplant immunosuppression because we wanted to decrease the risk of graft rejection. Followed by PCR alpha beta HSCT from the father. Now he's almost 4 years old, almost 7 years post-transplant, complete chimerism, going to school, growing well. The question about PTIS again can be decided based on the child's condition. This child luckily came to us very early and he was very stable. However, if we feel we don't have that much time, or for some reason we feel the child may not tolerate PTIS, just going ahead with the TCR alpha beta is better. However, we did that for one child where we thought we didn't have time, and he promptly rejected the graft. So again, it makes more sense if we can do some amount of PTIs before these sort of haplotransplants. And as we said, TCR alpha beta there is data on TCR alpha beta now. Of course, everywhere we know from India as well, we have a lot of data. And immune reconstitution, this goes through for any sort of TCR alpha beta transplant, as we know. Immune reconstitution can be delayed post these transplants, and therefore now more and more we are using the CD45 AdBank, which is known and is showing to improve immune reconstitution post transplant. Another scenario is the 2-year-old boy underwent similar TCR alpha beta depleted haplotransplant from his dad. The boy had MPS, had complete chimerism. However, he developed acute skin GVHD and required a lot of steroids, tamicerep, ruxolitinib. 2 years post-transplant, there was a sudden drop in HB to 3 grams per cent, and he had AIHA, which he treated. He required infliximab for AIHA. So the point here to make is that even though we are using a lot of haplotransplants, we need to be very careful about the development of immune cytopenias and autoimmunity, not just in MPS, but in other kinds of any transplant, but also in children with embolism, because there may be an impact of the disease on the HPA axis, and therefore more chance of getting these cytopenias. And we need to be very careful about how we are taking steroids. They may need low-dose steroids for a prolonged period of time. And this holds more true for these children with the next condition that I'm talking about, which is X-linked adrenoleukodystrophy. This is a story of an 8-year-old boy who was recently diagnosed to have X-linked adrenoleukodystrophy. He came to us, he was the only child. When he came to us himself, he came with a LACE score of 8. There was no matched family or a matched donor. We did haplotransplant from the dad. He grafted, had complete chimerism, was well until day plus 60. However, at day plus 60, there was drop in chimerism, there was progressive loss of the graft, and within 4 weeks of drop in chimerism, he had rapid deterioration of neurological status and he died. Another story is a 6-year-old boy who was well, no complaints at all. The elder sibling was actually evaluated for progressive neuro regression, and the elder sibling was diagnosed to have X-linked adrenoleukodystrophy, who we only counseled for best supportive care because he was very advanced. This boy was screened therefore because the elder sibling was affected, and on screening he was found to have a gene mutation. The MRI did show some subtle changes, however the base score was thankfully 2. He also underwent a similar haplotransplant like the previous child, and he had complete chimerism. He's almost 4-5 years now post-transplant, doing well, goes to school. However, needs a touch of steroids, which we are not able to come off, because every time he's trying to come off steroids, he's had AIH like the previous case that I spoke about. So the touch of steroids is required with this child. However, neurologically he's doing well. So X-linked adrenoleukodystrophy, as we know, is a condition where there is a mutation in the ABCD1 gene, and therefore there's accumulation of very long chain fatty acids, which results in inflammation and therefore cell death, and which specifically affects the neurological, the CNS and the adrenal glands. Some of them can just present with adrenal insufficiency to the endocrinologist, who then refers them to a neurologist, and then they get diagnosed. The LACE score is a very important score, which is required for us to decide whether we should offer transplant or not. As I mentioned earlier itself, it takes about 6 months for the stem cells to settle, produce enzymes, and to stop further progression. And if the child already has this borderline LACE score, which was the case in our first child, that progression can be very rapid. However, that child will have some graft loss, but even without that, we know there can be neurological deterioration in the first 6 months. So the general guidelines say LACE score of less than 7 are those who should be taken up for a bone marrow transplant, because they give you some time for cross correction. If they are taken up early, however, these children do well. The published data is of almost 90% overall survival. And LACE score stabilized or improved by 18 months after transplant. So it takes that long for things to settle in these children, except for patients with internal capsule involvement. Similar data also has been published by other groups, where major functional disability-free survival was seen in these children. So early transplant, almost 78% of them did well. And definitely there have been documented improvement in the MRI changes, and there's resolution, in fact, of the MRI changes over time. Similarly, if you can see similar reports by other groups as well. So the main debate in X-linked adrenoleukodystrophy is that whether, if like the second case that I spoke about, should we just monitor the child for MRI changes if the MRI is absolutely normal, or should we just preemptively offer transplant for everyone? And I think that it's not so much a debate anymore. The recent discussion also, the consensus was that if absolutely the child is normal, there are absolutely no MRI changes, we should do 3-monthly MRI and look for any start of any subtle changes. The moment there is any change in the stance of the MRI, we can counsel them or take them up for immediate transplant before there is further progression. Because the phenotype can be very different sometimes among the group of XLD children. So some of them can have no MRI changes at all for a prolonged period of time. So probably we need some more data in this regard, but the general consensus is to monitor the MRI. Now we move on to another similar condition called metachromatic leukodystrophy. This, however, story is not so happy generally for these children. This was a 2-year-old boy, previous sibling died of MLD, and therefore this child got diagnosed quite early. He underwent a matched unrelated donor transplant, and matched unrelated donor transplant, and he generally was doing well. He had 100% chimerism, and we had good follow-up. However, he has persistent peripheral neuropathy, and this is a known thing we know now with more and more data on MLD. Of course, there's a spectrum in this disease as well. Those who present early with more motor phenotype, like loss of milestones, ataxia, muscle thickness, polyneuropathy, and those who present later can have more of cognitive phenotype. However, all of these children need to be assessed by a neurologist, need to be assessed for peripheral neuropathy, and in general, in spite of a successful transplant, worldwide data has shown that there is progression of the peripheral nervous system. where it may be slower than expected, but there is. So the outcomes may not be as great as we hope for in these children. Again, most favorable outcome is among those who underwent transplant early and with minimal evidence of neurological. Now we move on to another case scenario, another disease which in India especially we will definitely see more and more. This is a 4-year-old child who was diagnosed with Gaucher's disease. She underwent splenectomy at 3 years of age. She had no compatible family donor. She underwent fully matched unrelated donor PDSC transplant. Similarly, we had another boy 2-year-old with Gaucher's disease who came with massive splenohepatomegaly. No obvious bony deformities, normal neurological function, and a fully matched donor transplant. And this boy, the discussion was that let's not do a splenectomy and we take him up with the spleen and the liver. Both of them had not received enzyme replacement therapy because of unavailability or for various reasons, and therefore they came the way they came. Both had undergone a similar conditioning regimen with flutiothiopipa. The second boy with rematched sibling did not receive EEG. Chemotherapy in general was tolerated well. However, there was hepatotoxicity, which we monitored and treated. There were lymphatic disturbances in both the children. Now, the first child who had undergone splenectomy had an increase in stunted engraftment by day plus 10. She had significant engraftment syndrome, respiratory distress, TAH, and she died by day plus 11. The second boy with the spleen had a lot of features of hypersplenism, even during transplant, required a lot of blood products and platelet refractoriness and features of coagulopathy. He had grafted by day plus 14 and a neutrophil and platelet by day plus 25. This is again old data, I'm sorry. He's almost 5-6 years now post-transplant, has complete chimerism, has no features of GVHD, is infection free, and there is over time there has been significant decrease in the size of liver and spleen. So Gaucher's, as we know, is a lysosomal storage disorder of somatic inheritance. Because of the deficiency of this enzyme, glucose heterosidase, there is deposition of glucose heterosidine, the macrophage leukocyte system. Important thing about Gaucher's is again there's a spectrum. There are those in Gaucher's who do not have neurological involvement, while there are those who have significant neurological involvement, and obviously the ones with neurological involvement we do not want to offer transplant. The main debate in Gaucher's is enzyme replacement therapy versus transplant. Now the scenario in India is that there is data from this Dr. Aman Agrawal where children who did receive enzyme replacement therapy had very good decrease in the liver size, spleen size, increase in weight, height, and cytopenia improved. They had improvement in bone pains, and 2 patients' neurological symptoms also improved. But however, the point to note is that over time, now that we have more long-term data on patients with enzyme replacement therapy, there is more and more documented development of antibodies and inhibitors, but the enzyme is not beginning to work as well. The problem in our country is that we know that this ERP was stopped through the humanitarian program in 2015. Only those who were previously enrolled were still receiving the enzyme. However, today we know there is a national rare disease project which is attached with several hospitals and a few centers in India where there is access to this enzyme if the children get enrolled in these schemes and the centers. Of course, we need to. So therefore, again, whether to transplant or not, we know again that those who do receive some enzyme and then taken up for transplant, the outcomes are significantly better. Recently, we transplanted a boy with Gaucher's who had received 1 year of enzyme replacement therapy, but he didn't have access anymore. But thankfully, because he received that 1 year of ERT through some scheme, he came generally in a better condition compared to the first 2 children that I spoke about, and touchwood is about 3 months post-transplant. So far, so good, and he's doing well. So therefore, we need, again, for any kind of transplant, we need a multidisciplinary team of doctors to do. In Gaucher's specifically, post-splenectomy lung changes can be significant, while those with the spleen hypersplenism can be significant. So whether to remove the spleen or no, if we do have enzyme replacement therapy and increase the spleen with that and then take them up for transplant, that's the best and ideal scenario. Um, so the another point when we come to IEMs is about enzyme level post-transplant. So this is a 19-year-old boy, Gaucher's disease, had a fully matched mother transplant, complete chimerism, regression of the hepatosplenum gallery. However, his enzyme levels continue to be suboptimal, maybe due to carrier mother. Now this concept also is changing. As we know, the earlier concept saying absolutely no to carrier donors is not existent anymore because long-term data says even if there is suboptimal enzyme, in general, the neurological and other outcomes can be sustained and they can improve over time. And especially if you don't have any other option, if there is a mud donor, that would be a better option. But if you don't, and we proceed with half-matched mother or father who's a carrier, it is something we can proceed with, and it's not an absolute contraindication. This boy, however, continued to have a lot of chronic skin musculoskeletal GVHD, which we thought was GVHD. We did prove it with some biopsies. However, there was also a component of progression of Gaucher's, is what we realized with this time because of the suboptimal enzyme. So this we know. So the most important aspect in children with Gaucher, with any sort of inborn error of metabolism, is long-term follow-up, and this is something that most families, when we counsel them for the transplant, and I'm sure everyone knows this, and everyone's a transplanter here. When we transplant them or counsel them for transplant, everyone is only worried about the life. Life has to be okay, the child has to be alive, the 2 weeks challenge, the supportive care, after that GVHD, day 100 mortality, and all of that. But once the child is out of the initial phase and it's 2 years, 3 years post-transplant, everyone is worried about how the child is looking, whether the child will be able to have a child of their own, fertility, everything becomes an issue. And we see this again and again because we have to counsel these families significantly and properly to say that everything is not going to disappear once you do the transplant. Long-term follow-up clinics are extremely important because, like, for example, this boy, 2-year-old with MPS 1, he underwent a transplant many years ago. 7 years post-transplant, he underwent surgery for kidneys. Now, recently, he had some, I think he had some avian or something for which he required surgery again. Cardiac-wise, he still continues to be on follow-up. Ophthal has improved, his cloudy eyes have regressed, and but therefore he needs follow-up. So these children need follow-ups for spine surgery. They may need spine surgery for giblets, for knock-knee correction. Height may or may not improve. They may continue to have short stature. Coarse patients may not disappear with time. Cardiac function does improve, but over time there is slow improvement in these children. And therefore long-term follow-up clinics are extremely important. So the lessons that generally we learn from all these cases that early HSCT is important for 2 years of age. Neuroregression may continue up to 6 to 8 months post-transplant. Pre-transplant immunosuppression can help in haplotransplants especially. And in X-linked adrenoleukodystrophy also, early transplant makes a difference. So I'll just share in the last 1 minute, I will take to just share some of the data what we've learned from our children. Actually, this is an old publication from our center on IEM transplants where we had overall survival of about 72% and 70% in haplos. This is the recent data that we've analyzed over 20 years, which is the latest data for 2025, where we included 22 MPS and Gaucher's and one child with Krabbe's disease, osteopetrosis and Wolff's disease as well. 52% of the transplants were from haplotransplants. Overall survival was about 88%. 9 children died, 2 with osteopetrosis, 1 child with Gaucher's, and the others between XLV and callers. Overall survival in the matched family donors was 88%, and in haplo was 82% and 70% in MUD. So this is just overall survival. However, there is a lot of long-term follow-up which we need to continue in these children. So among those with MPS, the children who underwent MUD donors had had normal enzyme levels within 1 year post-transplant. Children who received related and haplotransplant had low or suboptimal enzyme levels, although clinically they were well, but I think we need more follow-up on these children. Facial dysmorphism, corneal haziness, and organomegaly improved despite suboptimal enzyme levels. That's encouraging to know. Bone disease with kyphoscoliosis required orthopedic correction. Children who underwent transplant for Gaucher's, however, had complete resolution of organomegaly within 6 months. Children with X-linked adrenoleukodystrophy with a durable graft had stable MRI findings, and these children specifically need to be on steroids because we burnt our fingers with them having AIH the moment we tried to taper or stop the steroids. And among children with MLD, the story not so happy, they continue to have residual peripheral neuropathy, which needs intensive physiotherapy and rehabilitation. So we have a long hope before we can say we are there for IVF transplants. But thank you for the opportunity, and I'd like to thank my mentor, Dr. Revati, and my team here at Apollo, and thank you to Dr. Vikas Dua and Sohini for this opportunity.
Thank you, Dr. Ramya. Okay. Next, we have Dr. Neeta Radhakrishnan, and she's a consultant HOD Pediatric Hematology Oncology at PGICH Noida. And she's going to talk about how emicizumab rewrote hemophilia care. Yes, please.
In the loaded Venus presentation. Good morning, everyone. I would like to thank Vikas, Dr. Rahul, and Sohini and the team for this opportunity. So I'm getting into a transplant session just because I'd like to catch in a bit. And thank you for allowing me to do that. So I will be speaking on how this, from generally in Hemon, we're seeing a lot of revolution as to what we can offer our patients. So this is one more revolution that has happened in the last few years, and which has helped improve the treatment outcomes of our patients immensely. So in hemophilia care, which has really evolved from plasma transfusions in the 1960s to concentrates, that is basically factor concentrates, which were either plasma derived or later recombinant, which all required intravenous infusions and which couldn't really prevent bleeds to a large extent. Even if you are putting them on a high dose prophylaxis, you would still have breakthrough bleeds and still have joint involvement. Now, for the last almost 10 years now, we have availability of more products which has really revolutionized the care. So we'll be discussing a few of them now. So again, this is important from a global perspective because overall, globally, there are patients who are living a near normal life. Now there are people who are going into their 60s and 70s, and world over people are talking about aging and comorbidities related to age-related comorbidities in patients with hemophilia. So, but in our country, we still have patients who probably survive till young adult or middle age and then die of early, or as in die due to complications of the disease, or suffer a lot from very early life because of joint morbidity. Even if we took out the data from the World Bleeding Disorder Registry from 6 centers which were reporting to it. So if you look at the median age of the cohort of what we are treating, of around 1,780 patients across these 6 centers, the median age is just 20, and majority are adult centers. So even in adult centers, patients, the median age is just young adults, that is 20, and we do not have patients going beyond 35-40 years of age. This is probably because our access to prophylaxis is very poor and our patients develop target joints very early in life. So when you compare it with other low and middle income countries, other low income countries, and of course upper middle income or high income countries, the patients who have target joints very early in life is higher in patients from India. So this is just one among the challenges of hemophilia care in India. Then there would be a lot many other like chronic disease management. So that would be similar to thalassemia sickle as well. The parent has to invest a significant amount of time and money in the treatment. There is early disability. There is poor access to treatment, especially if you have something called inhibitors, which actually changes the ball game completely differently because now you are at very high risk of mortality early in life. Inhibitor positive hemophilia A will be around 25% of our severe hemophilias. But treatment options are very limited after that. We need to give what is called bypassing agents, which were either recombinant factor 7 or activated APCC. The options of treatment are very limited because the access to treating with these very expensive agents are limited in many centers. So probably a whole of a state, there will be 3 or 4 centers which will be offering. So patient has to travel around 300-400 kilometers to avail this option. In Western setups, immune tolerance induction is done. Partly in India also it has been done. Only thing is it requires IV access, continuous care, and a lot of product availability for that. You need to be giving factor at least once in 2 days for this ITI to be successful, and continuously you should be giving it for around 12 to 18 months, and that also becomes challenging. So in this context, non-factor replacement is emerging as that was an unmet need why something new had to come in. And like in many other hematological and oncological disorders where monoclonal antibodies came in, and that is how it came in here as well. So now we have two different groups of non-factor replacement. One is factor VIII mimetics and one is rebalancing agents. So factor VIII mimetics are emicizumab and mimate, and these mimate is currently under trial, and emicizumab, the drug which we are talking about today, has been licensed for almost I think 8-9 years now, and it has kind of changed dramatically the way treatment is being offered to children with hemophilia A, both with or without inhibitors. Now the other group of disorders, rebalancing agents, all of them basically resets hemostasis. And so now here again 4 drugs which are there, and 2 of them have already been licensed and the third is just about to be licensed. And again, in rebalancing agents, the interesting thing is that you could use it in hemophilia A or B with or without inhibitors. So now we have a product which is available across all hemophilia, and many of these products now can be administered subcutaneously once in 2 months. So from weekly 3 injections to now we have come to 1 subcutaneous injection once in 2 months. So that will be 6 injections in a year, and that will completely prevent bleeding, and that's how dramatic the treatment has changed for these patients. So emicizumab is a monoclonal antibody. It's a humanized monoclonal IgG4 antibody. Basically, it does the work of factor VIII. It links factor 9A to factor 10, and then downstream everything happens similarly. So if you have 8 or not, it does not matter. If you have an antibody against it as an inhibitor or acquired hemophilia, all of this condition, it does not matter because it's a mimetic and it's completely replacing 8 in your system. It has no cross-reactivity, no structural relationship to it, so it does not matter whether you have high titer inhibitors or not. And here again, it may work in some other conditions, we'll come to that in a bit, but basically it replaces the role of 8 in your system. The FDA approved dosing is 3 mg per kilogram once a week. Subcutaneously, you give it for 4 doses as a loading. And then subsequently, you have 3 options of infusion and 3 options of injections, and that could be patient or caregiver preference. So it could be weekly dose, 2 weekly dose, and 4 weekly dose. Essentially, does not make much of a difference. And this doses, if you see, the doses will give you ultimately after the loading, it gives you a kind of a trough level, and that level kind of a mean steady state concentration is maintained throughout, and that's how we are preventing. So at this dose, when you are giving, you are offering of around correction roughly equivalent to around 40% of factor VIII activity. So you are nearly normal. You don't have any spontaneous bleeds definitely, and you could pull off minor surgeries. You could do, patients can have reasonable amount of activity without any additional cover at all. So this has been used for aid with or without inhibitors, and this is extensive clinical development that has happened over the years, multiple studies that have come in. So as usual, it started in adults and older children, then in pediatric, and then initially with inhibitors, and then later without inhibitors, and then later you had patients who have been tested on a higher dose of like 6 mg per kg once in 4 weekly dose were also tested. Good numbers of patients, good follow-up also to show that. And in trial data, they showed that the treated bleeds actually came down significantly. Treated spontaneous bleeds came down. So these are cohorts of patients usually who would have anywhere between 12 to say 30, 40 bleeds per year. And then when it comes down to less than 1, that is a significant achievement for these children. Giant bleeds recovered. And for the first time, we started hearing things like zero bleeds and target joint reversals. So you can see how zero bleeds also increase over a period of time. So now cohorts of patients who never had a bleed in the last 1 year, which was unheard of earlier. And again, target joints. Earlier the teaching was once a target joint, it will remain forever, even if you do good amount of exercise and surgery, etc. But now suddenly the ones which at least you can target, you can catch them early, they all completely resolve with good physiotherapy. So that's something which we all saw. So this was essentially trial data from HEMENEXT 1 to 4, and patients slowly nearly approached 100% target joint reversal as well. And then it was tested in an Asia Pacific setting also in HEMENEXT, and then for surgical procedures also. So for minor surgeries, they could pull off surgery without any additional cover, whereas for major surgeries, you would need an additional treatment. So if it is a inhibitor naive patient, it would be 8, and if it's an inhibitor positive patient, it would be 7. There was also a recommendation not to use ABCC along with this drug, so slight increased risk of thrombosis. So there is a warning against using it. Then Haven 6 came in, and Haven 6 looked at, now so far it was only severe, now it started looking at mild and moderate hemophilia also, and here also there was improvement, there was better quality of life as expected. Now 7 looked at infants with hemophilia, so as young as 9-day-old infant, start was given. And this data again was recently published, which showed that only bleeds which they saw was only traumatic bleeds in that small baby cohort, where maybe it's due to somebody holding them tightly or falling off the bed, etc. And whereas there were no there were no patients who had any major bleed, no significant ADR. So one would be worried to give such a drug in a baby less than like 15 days old, but then they did not notice any significant adverse effects at all. And then a large phase 3 opened to look at patients, multi-center patients, and here again it was proven that 10 patients, these are again inhibitor positive patients, around 190 patients, were analyzed in the Stacy study, and they also showed that nothing significant happened. So ABRs improved, zero bleed rate was documented in around 40-50% in all studies, and later in real world data it was much better, zero bleed rates. SAEs, nothing significant. Initial studies had doubtful TMS, but nothing which actually led to the death or withdrawal of a product, etc. And any monoclonal antibody, there is a doubt whether there will be an antibody which is developed against that drug. And here again, there were in the trial data, they looked at anti-drug antibodies, but nothing which actually clinically interfered with. So as clinicians, what should we be worried about when we are using it? One thing, practical issues is we cannot use any clotting studies here after you start using. So clotting, one-stage clotting based assays like AP50, factor VIII levels, etc. We cannot use the same tests anymore. If you need testing, you need to be using chromogenic factor VIII activity, or you need to use global coagulation assays while you are on this drug. And this is true for all factor VIII mimetics. So the new one which is also under study will also have the same issues. And we could also look at any drug calibrator. There is a calibrator which is available, which can be calibrated to your existing automated coagulation analyzer, which can give you drug levels. It's like a parallel being drawn, and that again tells you what is the level of the drug that is there in your system. It's not a direct ELISA, and it is kind of you're kind of calibrating it against your regular factor VIII levels. So these are the tests which are affected, and these are not affected. In practical use, it's only in a surgical setting or a breakthrough bleed that you would need all of this. Generally, breakthrough bleeds do not happen significantly. And now there is off-label use in a lot of other conditions like hemophilia B, factor 11, BWD, Lanzmann thrombostomia, etc. Also people have started using, and it has been found to be thrombin generation is found to be good, and bleed prevention is also been there. So now the only issue is cost. Now the cost, because of the cost, the use in lower middle income countries is highly restricted. So whenever, if you are do not have an option to use it for all your patients, and it's only restricted by the cost and availability, then you may select from your cohort the patients who are difficult ones, like the inhibitor positive ones, and that too those ones with arthropathy, difficult bleeds, etc., or an unsuccessful IgA. You may also select it in patients who are very poor venous access, because then again, if this product is subcutaneous, it can be used easily in those patients as well. So these are some of the patients where we have used, this is like massive bleeds which have come in, kind of a peritoneal bleed which has gone on as pseudotumor into the abdomen, pseudotumor again in the hands. You can see how beautifully it has responded, intracranial bleeds, massive GI bleeds, burns kind of condition. So this was published, one of the earlier papers that came out, which showed actually that the bleed rate after you switch to the drug is actually almost zero. None of them had a spontaneous bleed, and of course children run around, there may be trauma-related bruising, but none of them require treatment. And subsequently, there are papers which came out later also, which showed more number of patients, some of them uninhibitor naive patients, and some of them uninhibitor positive patients, which has been used. And this is something which we tried. We tried a lower dose because now globally people are moving towards low dose because of access issues. And so here again, even in low dose, standard dose versus low dose when you check, the number of the bleeds were not significant. They have not improved. There is no worsening of bleeds even if you give 50% of the dose, and even the HHS scores also improve big time. And now for the most important part, which is the cost. So if you treat on a patient access program which is currently given in the country, and if you treat, it is actually the one bleed in a hemophilia A inhibitor positive patient, treating with bypassing agent would be equivalent to 1 year of treatment with the non-factor replacement with the current patient access program that is there. So there are multiple things which have changed, and this overall, even if it's an investment, the overall indirect costs, intangible costs, bleed zero, the outcome of these patients have improved significantly, and that's how treatment has really changed for this patient. And this is an editorial which says that even if you reduce dose, it will actually improve the number of patients that you can treat, and that's how it can actually become equitable for patients across the, it will increase the outcome, access by around 50 to 25%. So to conclude, the landscape has really changed in this group of disorders as well. This is more like precision medicine now, and now when more and more products will come, it will be like there will be also a question of who should get what. So that discussion is coming up already because now there are new products which have been just licensed. There are multiple options now, so we have to get to choose what is there. Probably gene therapy coming up. Younger children may be preferably taken for that because it gives a one-stop solution, but nobody knows what is the level at which factor VIII will continue after the gene therapy. After like 10 to 15 years, will there be a fall, etc. Those are things which are discussing. So it is a game changer, but the game is still on. It has not ended. I think the space will continue to evolve in the days to come. I thank my team and for this opportunity.
Thank you so much, Dr. Neena, for such a valuable insight. Any questions anyone has? No? Okay, we will move on to the next. We have Dr. Neha Rastogi, who is a senior consultant hematology at Anta Hospital, and she's going to talk on the role of HSCT in inherited bone marrow failures and how far have we traveled in 2025.
So a very good afternoon to everyone. And today, firstly, I want to pay thanks to Dr. Vikas and his team for giving me this opportunity. And coming straight to the topic, which is the role of transplant in inherited bone marrow failure syndrome. How far have we traveled in 2025? So there is a very old song. मुसाफिर हूँ यारों न घर है न ठिकाना मुझे तो बस चलते जाना सो चलते चलते 2025 में आ गए बहुत सारी चीजें चेंज हो गई हैं बहुत सारी सेम है so let's start. So we all know what are inherited bone marrow failure syndromes and treatment of choice is transplant because gene therapy is still not available for most of the diseases and target margins. So before going to the transplant, there are a few questions which should be answered. Should we give androgens before transplant while waiting for an alternative donor? So according to Dr. Carvin, we should start with the low dose androgens if we don't have a donor. Here in our India, in our centers, we are using haploidentical donors. But if the family is not ready for a haploidentical donor in the absence of MSD, then you can start androgens. But androgens have the effect on the liver functions and lipid profile, which can affect your outcomes later. Should we screen the family donor? Yes, definitely, because the many family donors don't have the same phenotype as the patient. Does myeloid malignancy risk depends upon the mutation? Yes. There are few mutations in which the myeloid malignancy appear early and there are few in which it appears late. So coming directly to the most common type of inherited bone marrow failure, which is the Fanconi anemia, in which there is an impaired DNA repair, because of which there is chemotherapy and radiation sensitivity. So when should we do the transplant? The transplant, as per the recommendations, is that you should do with the onset of pancytopenia and ideally before the initiation of the chronic blood transfusion, severe infections or evolution to the MPS or acute leukemia. So what it means that if your child is not having any transfusion dependent pancytopenia, you can wait. You can start infusions, you can wait. But if the child develops some pancytopenia, which is severe enough that you have to give the blood transfusion, then you should do the transplant. Otherwise, the transfusion problems related to chronic blood transfusions will be there, infections will be there. And if, God forbid, MDS or acute leukemia develop, then the prognosis will be bad. So, what are the important considerations in anemia transplant? सबसे पहला है radiation. So we all know कि radiation से it leads to increased chromosomal breakage, because of which the transplant outcomes are poor. Second is the busulfan or other conditioning alkylating agents related excessive regimen related toxicity. Third is GVHD. GVHD से तो सभी परेशान रहते हैं, but chronic GVHD is much more problematic in the case of pancytopenia because it increases the risk of solid tumors in the pancytopenia children. Also, the dose of PTCY. So for the hepatorenal transplant, you can have the PTCY or PCD, but in case of PTCY, the PTCY targets the donor cells which have the intact repair mechanism. What it means that you are giving the PTCY to reduce the incidence of GVHD. This PTCY has to act on the donor cells which are the normal cells. They don't have any independent mutations. So you need good amount of cyclophosphamide to get the GVHD prophylaxis. Now coming on to the various papers which have recently published. So first one is this which is published in Blood in 2024. It is from Europe and it shows the outcomes of hematopoietic stem cell transplantation in 830 pediatric patients with anemia. So the main highlights from this paper were, this is one of the largest multi-centric studies of pediatric anemia transplant, and the 5-year overall survival was 83%, event-free survival 78%, and GVHD left-free survival was 70%. The most important thing is the key predictors of the worst survival. So in which patients do you see the bad prognosis? When the indication of the transplant is AML or leukemia or MDS versus when there is bone marrow failure. If you have a mismatched donor, then also the prognosis is poor. Non-standard conditioning and age more than 10 years are also associated with worse prognosis. This paper has a very low graft failure rates. Anemia has a very high graft failure rates. Why? Because you are not able to give full conditioning. You are using less conditioning. That's the reason why high failure rates. But this was a paper in which they show very low graft failure, only 2 to 3%. And their 5-year cumulative incidence of secondary malignancy was also low, it was only 2%. So, in a nutshell, they have used the conditioning which has done the job in their case. There's another paper in BMT journal in 2024 in which they studied the predictors of outcome in HSCT for anemia. So, they have studied a total of 89 patients, and the factors which were showing the negative predictions were age more than 19 years, HLA mismatch, and the year of transplant. In the if the patient is less than 19 years, so they have found that TCD, T-cell depleted transplants have a more worse outcome than a T-replete graft. Usually in India, most of us are using the T-replete transplants for anemia because of the cost, because T-depletion itself will cost you extra 12 to 13 lakhs. But in this paper, they have shown that the T-cell is not good. You are spending extra 12 to 13 lakhs, and even then you are not getting good results. They show a very low GVHD rates. The graft failure rate was more in TCD than T-replete, and post-transplant malignancies was seen in 6 cases out of 89 cases. Then this is the highlight, which is a paper from Carmen Boffin. We all know her. She is the mother of transplants of anemia. So this is a review article which was published in 2022. So this first slide shows her conditioning regimen in the cases of match sibling donor as well as in the cases of mud. So the first A side, they are showing the match sibling donor conditioning in which they are using only cyclophosphamide. So earlier they haven't used anything else, just cyclophosphamide. But later on, then took the dose of 60 mg per kg, total divided in 4. But then what they saw, the incidence of GVHD was high, so they added the ATG. But this was the less syndrome. Down here, where the mud conditioning is there, they are using the fludarabine also. For the prophylaxis of GBS, they use cyclosporin and methotrexate. Now, the next few slides will show the conditioning for the haploidentical transplant. So, this the slide, this was the initial conditioning in which they have done the 14 patients. The 14 पेशेंट में थे, शुरू के जो 5 पेशेंट थे, उसमें उन्होंने cyclophosphamide पे यूज किया था. So, the total dose of cyclophosphamide withdrawal is 60 mg per kg. So, what they have done, they have used 50 mg per kg in the post-transplant prophylaxis for GVSD, and they have used the 10 mg per kg in the initial part. But the mucositis rates were very high, because of which the TRL was high. So what they did, only in the first 5 patients they have used the pre-transplant cyclophosphamide in conditioning, and then they have stopped using it. Even after stopping the cyclophosphamide in conditioning, उनका कोई भी engraftment rates affected नहीं हुआ, and so that became the standard of care in their regimen. They were using the oral MMF. Oral MMF has two problems. पहला कि जो है oral MMF itself causes diarrhea. Second problem is that it is not getting absorbed because of the diarrhea and mucositis, and the GVHD rates increased. So the oral MMF was inadequate to cover for GVHD, and high diarrhea was happening. So what they did, in the next step they changed it to IV MMF. तो अब सेकंड टाइम में उन्होंने 39 पेशेंट्स किए, एंड इसमें उन्होंने व्हाट चेंजेस करते हुए फर्स्ट IV MMF, and second they have removed the pre-transplant cyclophosphamide, but there was no impact on the engraftment. So in their cohort, around 70% children have the CMV reactivation. They were also using the 2-grade TBI, and the dose of rapid ATG initially was 4.5 mg per kg total dose, then they have increased it to 7.5 mg per kg total dose, and the effect was significant. So if you see in the previous slide, there was no ATG. In next, they were using ATG. So the incidence of chronic GVHD as well as acute GVHD dropped down drastically. But अगर इसको change करना था बैठे-बैठे बोलोगे, तो what they did? They thought that they will stop using the ATG. Now what they will do? They will start using the campaign. So in conclusion, they have used the campaign. All engraftment, all well, but the clinch here is that ये patients में 80% CMV reactivation, and the CMV lasted for 6 months, 5 months. In India, if you have CMV reactivation for 5 to 6 months, कोई ना बचेगा. So this, and even then they also realized this, and they have gone back to using ATG. Also, what they have done, they have tried to reduce the dose of TBI from 2 grade to 1 grade. What it does, it has the, उसके बाद 3 patients में किया, एक में rejection हो गया, तो वापस 2 पे आ गए. फिर और क्या किया, उसको करना ही था. तो what they have done, they have increased the dose of post-transplant cyclophosphamide from 50 to 60, but there was no reduction in GVHD rates, but there was increase in mucositis. So they have come back to the original one. तो जहाँ से चले वहीं आ गए. So this were all the lessons from our Dr. Carmen. So out of all this cohort of 63 patients, 5 patients have DSA positive, in which they have done the pre-transplant immunosuppression. So the lessons learned were that the omission of pre-transplant 10 mg per kg cyclophosphamide reduced mucositis and has no effect of engraftment. And also a use of IV MMF and use of serotherapy. So this is a paper from Dr. Raj and Dr. Ramya, and they have shared their own data for the transplant of anemia. The important things they showed were that if they used the NAC pre-transplant, then the grade 3 mucositis incidence decreases. Also, they have done the ferritin-based monitoring for early cytokine release. So उन्होंने क्या किया? वीक में 2 बार ferritin monitoring की. और अगर if your ferritin is increasing, then they added the IV methyl. Early steroid initiation and early tocilizumab improved the clinical stability. And the birth survival in their cases were more than 15 transfusion pre-transplant and ferritin more than 10,000. So this was the other paper which is published recently in 24, in which they have shown that the addition of ATG has decreased the incidence of GVHD. So now, this is a paper which was published in 2017, old paper, but very famous paper from Parinda Mehta, in which they have talked of radiation-free alternative donor transplant for phenylketonuria patients. So it was the budget of the town at that time, and this was the conditioning. They have used diglycerfan, fludarabine, cyclophosphamide, and ATG, and they have not used TBI. But the main problem with this was that the incidence of CMV was very, very high. All the patients, they were able to salvage, but they were using virus-specific T-cell therapy also, which is costly, not available. So this protocol is difficult to use in India. So this is a paper from Franco Locatelli in which they have shared their data for the HLA haploidentical TCR alpha beta transplant for phenylketonuria. So any views on something new, which is the most important point here. So recent news is about the Stanford new experimental graduate. This came first in news and then in paper. So a recent report shows that the Stanford describes a stem cell transplant without a toxic condition. So क्या किया इन्होंने? So they have used the antibodies against the CD117 and they have used the alpha beta depleted T cell transplant. No radiation, no traditional chemo, busulfan was used. They have done it in 3 children and like the follow-up period is of 3 years and all 3 are doing good. No graft rejection, no GBLD. So the woman behind it is Dr. Rashmi Agarwal, who is from the Indian region. So this was a paper which is recently published a month back in September 25. Irradiation and busulfan-free stem cell transplantation in phenylketonuria using our anti-CD117 antibody. So this is the conditioning. If you see on day minus 12, they are using this antibody briquilimab anti-CD117 and then ATCs and flutarine cyclone. तो यहाँ पर एक जो इन्होंने वो किया वो ये है कि they have written irradiation and busulfan free, but they are also using the conditioning. This is because CD117 is only on the myeloid cells and they are not expressed on the lymphocyte. तो lymphocyte तो बच जाएंगे ना, तो उसके लिए थोड़ा conditioning का use करना ही पड़ेगा. And then one thing more in this transplant, they have to see the levels of this CD117 before transplant. So if the levels are high, then they have to postpone the transplant for a few days. And they enrolled and screened 3 patients and they have completed the follow-up of these 3 patients. The minimal toxicities were mucositis, there was no VOD, neutrophil engraftment was at day 11, robust donor titers for up to 2 years, and RBC platelet and lymphocyte recovery was comparable to the previous reports with TCR alpha beta, T cell depleted and CD19 depleted grafts. All patients are alive and well with the resolution of earlier chromosome breakage abnormalities. So the first patient who benefited from it was Ryder Becker, who is now 11. He has received transplant in UC Packard Children's Hospital in 2022 and has recently finished his 5th grade. He is using some of his newfound energy to play sports. He loves pickleball and received an award from his school soccer ball. So here what we need to understand is that CD117 is not expressed on lymphocytes. So हमने अगर खाली इसको conditioning में use किया तो you will be left with the host lymphoid cells because of which there will be graft rejection. So you need to do some chemo with KD. But CD45 is widely expressed in hematopoietic cells. It is in the mature leukocytes and bone marrow progenitor cells. They all express CD45. तो अगर आप CD45 वाले antibodies use करोगे तो we have better reduction in the bone marrow clearance and you need not to use any conditioning. So this is the mice model published in 24 in blood by allo engraftment without significant toxicity or GVHD in CD45 antibody conjugate condition phenylketonuria. So this was the paper and there was this paper was on mice. It was difficult to understand that paper. There is an editorial attached with this paper. I read that one, that was very easy to understand. And that showed that 3 mice model use किए थे, एक phenylketonuria A का, एक phenylketonuria C का, एक phenylketonuria G का, और उसमें एक उसके साथ जो कंट्रोल था, उसमें उन्होंने TPI दिया, जो हमारा माउस मॉडल था, उसमें उन्होंने CD45 PMD equivalent जो है एंटीबॉडी दिया, and what they found that there was equal engraftment and there was a significantly reduced acute GVHD without any serious toxicity. So it was good. So now coming on to the next type of non-error of metabolism, DKC transplant. So the conventional intensity regimens are associated with increased pulmonary and hepatic toxicity, frequent decreased transplant toxicity and improved survival, presumably by reducing the need for extensive cellular repair and limiting the consequences of effective telomeral function. So we are hematologists, so we look at the hematology. But if we have to see the patient in a whole, we can't just focus on hematology. So अगर चाहे हम आपका पेंटिंग एनीमिया हो चाहे आपका डीकेसी हो, तो ये जो म्यूटेशन है वो सारे सेल्स में प्रेजेंट है, जस्ट हेमेटोलॉजी वाले सेल्स में प्रेजेंट नहीं है. तो अगर आपने किसी डीकेसी के पेशेंट को बैक दे दिया, तो लॉन्ग टर्म में what will happen? He or she will have lots of complications. Also, even if you are giving the rate, even then the long term outcomes you have to see for complications in other systems, because ये जो आप conditioning दे रहे हो, इतनी toxic medicines दे रहे हो, they are going to affect the other cells of the body which have the mutation of DKC. जिनके अंदर telomerase shortening role आती है. So what are the problems? You can have complications like graft rejection, graft failure, GVHD, sepsis, pulmonary fibrosis, hepatic cirrhosis, and bleeding. So most of the patients who are transplanted for DKC, later on they die from the hepatic or pulmonary complications. So long-term follow-up is important. This is a recent paper from 2024 where they have signified the importance of RIC in DKC. So उन्होंने क्या किया, दो कोहॉर्ट है, एक उनका ट्रेडिशनल कोहॉर्ट है जिसमें 12 पेशेंट्स हैं, एक उनका नया RIC कोहॉर्ट है in which they have excluded the 2-grade TBA, otherwise everything is same. And what they found is the acute GVHD, chronic GVHD, overall survival, everything is better in non-TBI group. However, there is little mixed characteristic in non-TBI cohort, but the lymphocyte reconstitution is better and the overall survival is same. This is another paper which is recently published in which also shows the importance of RIC in DKC. And this is the recent paper in 2025 which showed the analysis of late complications associated with transplanting patients with DKC, in which they have talked about like pulmonary fibrosis, pulmonary atriovenous venous malformation, liver fibrosis, and hepatopulmonary syndrome. So at last, we come to the summary of what all changes we have here in the transplanted inherited bone marrow failure syndrome. So first is the improved survival. Second is the donor source. We all know that the match-fitting donor is always better than mud or haplo. Conditioning in any kind of inherited bone marrow syndromes, you should prefer RIC, especially if drug based. GVHD prophylaxis, always use serotherapy and optimize the GVHD prophylaxis, because these children have mutations because of which their cells, even of other systems, are predisposed to early death. Then comes the chimerism. Missed chimerism is acceptable, especially if stable and without GVHD, because it may reduce toxicity while still correcting bone marrow failure. Late complications, even after successful transplant, these patients remain at the risk of secondary malignancy, and long-term follow-up is critical. Age. Older ages transplant is related with the high TRM. Early transplantations, before patient can accumulate many transfusions or develop the clonal condition like ambulance agreement, is always better. So last but not the least, thank you everyone for your patient listening, and that's all from my side. Thank you. Any questions? Thank you.
अभी है पैनल डिस्कशन, ठीक है, इसको कैमरा म्यूट करो.
Thank you so much, ma'am, for that amazing session. Next in line, we have a panel discussion by Dr. Sunisha Arora. She is an associate consultant in Fortis Memorial Research Institute. The stage is yours, and you can kindly introduce your panelists.
Good afternoon, everyone. So I'm Dr. Sunisha Arora, and I will be the moderator for the session regarding the pharmaco-revolution, which will introduce the latest drugs in hematology. And the panelists are Dr. Rahul Sharma. So may I have you on stage, please? Dr. Richa Singh, Dr. Ruchi Chaudhary ma'am, Dr. Shivani, and Dr. Nikhil Gupta. May I have everyone on stage, please? So in this session, we will be discussing certain drugs which are newer in hematology, which are new to us, just like all of us. So the aim will be to review the strength of current evidence of these drugs, to understand which therapies are ready for routine practice which can be implemented, and to identify the areas where data remains preliminary and we have to be watchful and we have to keep looking for the space where the new data is coming up. So case 1, a 6-year-old boy had chronic anemia, mild jaundice, and intermittent scleral interest since infancy. He was diagnosed with some hemolytic anemia at the age of 1 year and was receiving transfusion every 3 to 4 months. During the current illness period, there was no family history of hemolytic anemias, and on examination, he had splenomegaly, which was 4 centimeters below costal margin, and no hepatomegaly. So these are the investigations. Low hemoglobin, elevated LDH and retic count, elevated indirect hyperbilirubinemia, all in favor of hemolytic anemia. And on genetic testing, he was found to have homozygous PKLR mutation. So Dr. Rahul Sharma, so what is the diagnosis?
So as a patient is homozygously has a mutation of PKLR, so it's a pyruvate kinase deficiency, which is a non-spherocytic hemolytic anemia. And so the new drug on the block is mitapivat, which has recently come and approved in 2022 for the disease. So it's an allosteric inhibitor which binds on the pyruvate kinase enzyme and activates it activates the enzyme actually. By changing the conformation and doing the stabilizing the active conformation in tetravalent state. So in that way, it converts the pyruvate, phosphoryl pyruvate to pyruvate, and thus increase the production of your ATPs. So increases the metabolism of the cells, prevent they strengthen the membranes. So it prevents the premature dissection of the membrane. So that way it prevents the hemolysis. This is how it works.
Yes. So that's how it stabilizes the membrane of RBCs. So now coming to the adult trials, because since all the pediatric trials are derived from the adult trials, which adult trials are we talking about regarding mitapivat, which have led to the evolution of pediatric trials? Dr. Richa.
So there are 2 trials in adults which have been done in 2022. That is Activate and Activate T trial, depending upon the requirement of blood transfusions. So Activate trial was done in patients who were non-transfusion dependent pyruvate kinase deficiency, and Activate T trial was those who were transfusion dependent. That is receiving 6 or more than 6 transfusions in a year, and they were adults and they had PK mutation was there, PKLR mutation, and maximum of them had undergone splenectomy or cholecystectomy. So there were total 80 patients enrolled in that trial. Those adult patients were divided, it was an RCT, and it was divided between adults, those who had received mitapivat and few received placebo, and it was done in 2022.
So the Activate is the landmark trial which had led to the use of mitapivat in adults. The primary endpoint of this trial was to see the reduction in hemoglobin or the reduction in the requirement of transfusion by 1/3. If the patient has developed the transfusion reduction in the requirement by 1/3, that is considered to be the primary endpoint. And it was found that 40% of the patients on mitapivat achieved this endpoint. So this was the key inclusion criteria. Only adult patients were taken into account, and they had at least 2 mutant alleles in PKLR, of which at least one is a missense mutation. So very important to note the type of mutation will define the outcome of mitapivat in the patients. In the patients, if at least one of the missense mutation has to be present for the mitapivat use, and only then it will be useful. So exclusion criteria were homozygous for R47-9, 479H mutation and 2 non-missense mutation in PKLR. So, Dr. Rachi, can you highlight the results?
Yes, 2 wonderful trials were done in adult patient, as Dr. Rachna has mentioned about these. So basically, those who required less than 4 transfusions in a year, or those who required more than 6 transfusions in a year, they were divided into two groups, which one were transfusion dependent, and so the activity trial covered those patients, and they found wonderful results in both the the cases, both the trials. In Activate trial, they found some 40% patients achieved uh, the increase in the hemoglobin, and almost the mean hemoglobin rise was some 1.6 gram per dl, which is quite good. And basically, the most important aspect was the pyruvate kinase enzyme get involved in other organ functions also. So the overall improvement in the patient of their clinical status was also significant. And in Activate T trial, they found that 33%, almost I think 33% patients achieved the similar results of increase in the hemoglobin. So yes, requirement has reduced in both the cases, and overall efficacy is quite good.
I agree with you, ma'am. Because of these fabulous results, it was included in to be used in adult patients based on these two trials. Now, may I ask Dr. Shivani, why do some PK deficiency patients fail to respond despite giving the adequate dose? Is there any correlation with the type of mutation?
Yeah, so ma'am, as you have already highlighted about inclusion and exclusion criteria, the answer comes from there as well. Like the ones who have at least one missense mutations, they tend to have a better rise in the hemoglobin with mitapivat, apart from the ones who have at least two non-missense mutations, and also R479H, which is a missense mutation, but still they tend to do bad with mitapivat because they have some kind of activity issues, and that is why they do not have adequate rise in hemoglobin with mitapivat. Yes, that's true. So missense makes sense in the case of mitapivat. Now, Dr. Nikhil, is there any correlation of hemoglobin response with the baseline PK protein level?
So basically, those patients who have high PK protein level, so they tend to have a better response as compared to those who have low.
Yes. So mitapivat needs some residual PK activity to be present to act on that enzyme. So that is why if the patient has some residual PK protein, the response will be better. As we can see in this study, if the residual protein value was 59%, those patients had a better hemoglobin response compared to the patients who had a mean value of 14% who did not respond to mitapivat. Dr. Richa, what are the results of Activate T trials?
So as ma'am said earlier, that in activity, that is transfusion dependent pyruvate kinase deficiency, there was more than 35%. It was found that there was reduction in number of blood transfusions in patients when received mitapivat, and there was also more than 20% reduction in that the patients were transfusion free after mitapivat, and around 10% of the patients, the hemoglobin came to normal values.
Dr. Rishi, what about the pediatric studies? What have we learned from these pediatric studies?
So, in pediatric studies, in pediatrics also, similarly, Activate Kids and Activate Kids T trial has been conducted, and they found almost similar results. Though the results seem like some 30% results are there, and they have divided it in three different groups, like those who have achieved transfusion those who has achieved the normal hemoglobin, absolutely normal, those were 12%, those who were transfusion free, some 18-20% patients were absolutely transfusion free, and who had reduced transfusion requirement, and the average hemoglobin rise was of 1.5 gram per dl. So that's the Activate Kids trial, and yes, that's still on. These are the three.
So the trial in kids has also mirrored the effect which were there in adults. So this is the dosing in pediatrics. For 1 to 2 years of age, the baseline dose which is used is 1 mg fixed dosing, and from 2 to 12 years it is weight-based. Less than 20 kg, 1 mg BD, 20 to 40 kg, 2 mg BD, and more than 40 kg, 5 mg BD. And for more than 12 years of age, it is again 5 mg BD. This is the level 1 dose. So what are the common side effects? Coming to the side effects, Dr. Rahul.
So as this increases the production and cell turnover, so definitely it has more and more activity. So you can feel the bone pain, backaches, arthritis, or and all. Uric acid level can be raised, and liver toxicity is a major concern when you start a drug for initial months, especially the first 6 months. And it causes the off-target inhibition of your aromatase enzyme also. So you can have the less level of estrogen, particularly male. So you can have the it can affect your bone health, the loss of libido, the fatigue. All these issues can be there. And initial for few patients, initial insomnias can also be there, and some URTI kind of things. Lot of and one more thing, that when you stop the drug, it has to be stopped it has to be tapered very slowly. Otherwise, you can have rebound hemolysis. That is sometimes difficult to manage.
That should be kept in mind, that it should not be stopped abruptly, it can cause hemolysis. And other side effects, usually this metabolite is well tolerated, there are minor side effects, so can be managed. Long-term bone health, as we mentioned, long-term bone health and the hormonal levels need to be monitored. So can it be used in other globulopathies? Yes, there are trials, and it has been approved for thalassemia in some countries, but sickle cell is not yet approved and the studies are ongoing. So yes, yeah.
Pivot and Pivot. These are the two drugs in adults. They are still under trial, started in 2025, and it has similar action to Metapivat.
Yes. So we have to watch this space for upcoming drugs, but at present the cost is a limiting factor. Metapivat, I inquired for an 18-year-old child. The dose will be around 5 mg per 5 mg BD, and the cost will be approximately 20 lakhs per month. So this is a huge cost, and that needs to be taken care of. Next case 2. So 15-year-old transfusion-dependent beta thalassemia. Average transfusion requirement is around 2 units every 2 weekly, and ferritin levels of 4,500, and severe iron overload in the liver. And he's on irregular iron chelation. He was started on injection luspatercept. What is the mechanism of action, Dr. Nikhil?
So basically, this is a crucial protein where is the excessive domain of the immunoglobulin G, and then there is a modified extracellular domain of ACT-R2B. So basically, what it does is it basically binds to the TGF beta and it blocks the downstream SMART3, which invariably augments the
late stage of erythropoiesis. Right. So it acts on late stage of erythropoiesis. And what are the approved clinical indications, Dr. Richard?
Wait.
That's true. Now, how do you decide when to initiate luspatercept? Like, for example, in this patient who's on 2 weekly transfusion, is it the right time to initiate luspatercept or we wait? Dr. Richard?
Yes, when the transfusion requirement becomes so significant that almost every 1 to 2 weeks, if the patient is requiring the transfusion, then technically that's the time point we should start. So most of the time our adolescents and adult patients will receive this drug. Yes, that's.
And one thing should be kept in mind, there should not be any uncontrolled hypertension or marrow failure because these patients do not respond to this. Now, BELIEVE trial, which is a landmark trial, which has led to the use of luspatercept. Dr. Shivani, just highlight briefly on the points of the BELIEVE trial.
So BELIEVE trial, first of all, is a randomized phase 3 double-blind placebo-controlled trial for beta thalassemia transfusion-dependent patients more than 18 years of age. who are actually the transfusion requirement and the transfusion free period is not more than 35 days. They are included in the study. So one arm receives luspatercept, the dose is 1 mg per kg subcutaneously every 21 days, and the other arm receives placebo subcutaneously every 21 days, and the results were analyzed. So the primary endpoint of this study is to see like more than 33% fall in the transfusion requirement should be there, and it is given for around 48 weeks, but the primary endpoint results were analyzed at week 30 to week 24. And the other parameters are also analyzed like serum ferritin levels, the liver iron concentrations, as well as the myocardial iron concentrations. So ferritin, there was a response in ferritin, the p-value was significant, but liver iron and myocardial iron concentration decreased, the p-value was not significant.
Yes. So 21% of the patients achieved the primary endpoint, which was reduction in transfusion frequency. What markers help us to identify a non-responder early? Because there are few sets of patients who will not respond to this practice.
So basically, as she said, the goal the endpoint was that there should be more than 33% improvement in the decrease in the transfusion requirement. But if there is suboptimal hemoglobin rise or there is lack of 1/3 of the transfusion reduction, right, 3 to 6 cycles of so basically that's long-term response.
How aggressively should you escalate the dose who have fluctuating pre-dose hemoglobin? Dr. Rahul.
So once we should start drug with a very minimal dose, like 1 microgram, 1 mg per kg, and we have to wait for at least 2 doses, 3 doses, to see the trend of rising of hemoglobin. We should not say do like we are giving just 1 dose and we are expecting the response at the very next dose. And with every dose rise, you have to see the BP and you have to look for the bone pains and all other things also. Because this is, if you are not getting suboptimal response, then you have to go like 1.25 mg per kg for your thalassemia, and for MDS, the dose is bit on higher side, 1.33 to 1.75 mg per kg.
So maximum for thalassemia we can use
1.25
and for MDS we can use 1.7.
But at least wait for like 2 doses, similar doses before you do the next dose wise.
So talking about our patient, she developed severe pain in both the legs after 2 doses of luspatercept, and which was managed with painkillers. And now, Dr. Shivani, how will you manage bone pain which is severe, or a new extramedullary hematopoiesis which can happen after starting the drug?
So bone pain is a common side effect with luspatercept, which is most commonly seen during the first 3 months, and post 4 months onwards it goes on decreasing. So we need not to reduce the dose or discontinue the therapy. We just have to manage the patient symptomatically with painkillers. We can use paracetamol or NSAIDs. So that is not a worrisome problem. But the other thing, extramedullary hematopoiesis, for that we need to be watchful as they can progress during the therapy. So in that case, if it is leading to any mass effect or spinal cord compression, so we need to have a multidisciplinary discussion, and we might have to reduce the dose, or and sometimes we might have to stop the drug.
So extramedullary hematopoiesis is the major concern. So what other side effects which have to be looked for, Dr. Ruchi?
One thing is just before starting, as we check the blood pressure, hypertension is one of the contraindications to start, as the patient might develop that during treatment also. So that is one of the major side effects we should watch for. Another is, Shirani mentioned, with extramedullary hematopoiesis, sometimes seen with this as this drug is working to increase the hematopoiesis per se, and the survival of these maturation of the RBC precursors. So definitely extramedullary hematopoiesis is one of the risk factors. So we should examine the patient neurologically also. Sometimes another event can be thromboembolic phenomena. So basically these are the major side effects the patient should be looked for. Hypertension, thromboembolism, and extramedullary hematopoiesis.
Now coming to case 3, a 7-year-old female, she was diagnosed with chronic ITP and the duration was for 14 months. She initially presented with symptoms of ITP with platelet count of 8,000, received prednisolone, then received 2 courses of IVIG, followed by high dose dexamethasone, nothing was working. Secondary causes were ruled out. Now she comes to your clinic with a platelet count of 7,000 and other cell lines were normal. She had mild mucosal bleeding. And the parents were reluctant for starting with rituximab and they were preferring oral therapy over injections. And will you consider oral altromobag for this patient? Dr. Nikhil, is it approved?
Yes, it is approved. Initially, it was basically giving the money as a patients of chronic disease. And later on, this thing has been utilized in adults for the chronic ITP. And then finally, it is being approved in July 2025 for the children who are more than 1 year of age with persistent or chronic ITP.
So this drug is a very promising drug. How does this drug act, Dr. Ruchi?
This is a thrombopoietin receptor agonist, TPO agonist, which is basically non-competitive activator of thrombopoietin receptor. So it doesn't work on the same receptor where the thrombopoietin works. So that's one of the major things. That's how it works, and it increases the maturation of and production of platelets.
So Dr. Shivani, as ma'am has rightly mentioned, it acts non-competitively. What are the advantages of it being a non-competitive inhibitor?
Yeah, so we have lubiprostone, which acts at the extracellular domain. It is the place where actually thrombopoietin also binds, so it's a competitor. The other two drugs that we have is the trombopag and entrombopag. They bind to the transmembrane domain, so they are non-competitive. So the advantages they offer versus lubiprostone is wherever there's a period of stress, so the thrombopoietin levels they rise, and when the levels rise, so it decreases the efficacy of the competitive blockers. The other advantages is could be that like they lead the competitive blockers, they lead to the production of the TPO anti-TPO antibodies, which again decreases its efficacy. So these are
That's true. That's why the non-competitive inhibitors are better than competitive inhibitors. So, Dr. Richa, what are the pediatric studies favoring avatrombopag?
So there is EVA-P 301 trial. So EVA is avatrombopag for pediatric. 3 stands for the phase 3 trial, and 01 is by the company which is it has given the number 1 as a trial. So EVA-P 301 trial was in this trial around 75 patients, that is children and adolescents with persistent and chronic ITP were included, and they were given avatrombopag and for 6 months. So the primary outcome of this trial was the platelet response was a durable response, and the secondary outcome was the platelet response, whether there was elevation in platelets seen or not. So in this, there was a significant difference. It was found that 81% patient had an increase in platelet count, and around 28% it was a durable response. And it was found that out of 8 weeks, 6 weeks, the platelet levels were in the normal range.
That's right. 28% met the primary endpoint. That was a durable platelet response. So they have introduced a sprinkle formulation, which is very helpful considering they deal with children. So Dr. Ruchi, how significant is this new sprinkle formulation?
Sprinkle formulation is a wonderful way, as we are most of us are dealing with pediatric patients, and administering drug is itself challenging to them. And now we can just open the capsules and mix it with anything which child likes, and then we can administer the drug. So definitely that increases the palatability of the drug, and more compliance can be ensured with this formulation. So aspect, yes, we should consider it.
So many parents come to us, the child is not taking medicine. How will you give altrambopag? Child is not ready for fasting for 2 hours before and after altrambopag. So the advantage is it can be mixed with food. There's no interference with food intake. So what is the dose schedule for altrambopag, Dr. Ruchi?
For this was a child who is 7 years old child. So the starting dose will be 20 milligram. In the EVA-PET trial, they used two doses. There is one was in 1 to 6 years old kids. They started it with 10 milligram, and then more than 6 years kids, we will start it with 20 milligram, and then we will keep titrating it every 2 weeks and up to 40 milligram per kilo in more than 6 years of the age. Yes, that's what.
So the platelets are more than 4 lakh, we hold the drug and repeat after 2 weeks and restart at a lower dose. So what side effects are we expecting in this child? Dr. Rahul?
So this is a usually well-tolerated drug and not of much of side effects, but yes, some patients can have experienced the headache, the thrombocytosis, mild transaminitis can be there, and with the very seasonally rise and long term, you can have the risk of thrombosis, which is less than your conventional thrombopeg. All the side effects which are being mentioned, like bleeding kind of side effects, these are primarily the disease-related side effects of the trial. So this is not the drug-related.
So it's well tolerated,
Very well tolerated.
very well tolerated drug. And when we compare to routine practice, we are using L-Thrombopag. So L-Thrombopag is a very promising drug which can be used in our practice. And the advantage is it's not that costly as we think. One box of 28 capsule comes with only 16,000. It's available on India Mart at 16,000. So this is one change which we can bring in our practice. So next case, it's a 14-year-old male who was a high-risk AML patient, underwent a massive donor transplant with flu ATG conditioning and cyclosporin methotrexate GVHD prophylaxis. On day 65, we noticed there are some skin lesions, the tightening of the skin involving 10 to 15% of the body surface area. Started on steroids. Then at day 120, we noticed that there was worsening of the skin lesions and liver also started getting involved. So considering the steroid refractory GVHD, ruxolitinib was started. On day 180, he became ruxolitinib refractory. So now what to do? At day 180 post-transplant, he is steroid refractory and Jakavi refractory. Next. Any other options available, Dr. Nikhil?
So basically we know that for the chronic GVHD, the first line is steroid and then the second line is Jakavi. But beyond that, there were multiple options priorly. But now the belumosudil came as a FDA-approved agent which can be used in the chronic GVHD when you have failed 1 or 2 lines of the treatment. Otherwise, there are other options also like extracorporeal photophoresis, and some have used mTOR inhibitors.
Right, so now we have 3 FDA-approved drugs for chronic GVHD as second line, ruxolitinib, ibrutinib, and belumosudil. So what is the mechanism of action? Dr. Shivani.
So this drug primarily blocks the ROCK2 pathway, which leads to fibrosis and chronic GVHD. It restores the immune balance by increasing the Tregs and decreasing the T helper 1 and 17 cells, which leads to the production of the pro-inflammation. And it also down-regulates TAT3 and transforming growth factor beta, which is the driver factor in chronic GVHD.
Yes, so it has dual action. It promotes immune tolerance and also reduces the fibrosis. So what are the landmark trials which have led to its approval in our practice? Dr. Ruchi.
So, ROCK2 inhibitor and Rockstar is the trial as our kids are Rockstar. So that's what the trial is, and the drug itself has shown wonderful results. Some overall response rate is 75%. Yes, that's a wonderful response rate. So that brought this drug into quick approval. And the response remains sustained, and even the overall symptoms start improving very quickly. We can start seeing the response within 6 weeks, and the overall symptom improvement was seen in some 60% of the cases. So they compared in this phase 2 trial. Initially, they compared the doses, which were like OD dose, 200 mg OD or 200 mg PD doses. They found that there was not much difference in the response. So now the recommended dose is 200 mg once daily. And then we can use that in patients where at least two drugs have failed. So that's what the trial is.
Yes, ma'am. So this drug, it's very promising, has more than 70% of response rate. In a condition of chronic GVHD, where the second and third line, the patients are refractory to second and third line where we give only 30-40% of hope. This is a drug which can give more than 70% of response rate in these patients. So now apart from chronic GVHD, any other indication for this drug, Dr. Richa?
So it acts on the ROCK2, that is Rio dependent. This is a coiling kinase inhibitor, which is having an anti-fibrotic action. So two more indications in adult still under trial, that is in plaque psoriasis, and that is moderate to severe, as well as systemic sclerosis, and few patients of idiopathic pulmonary fibrosis. There also it has been used.
Dr. Rahul, coming to the pediatric patients, which patients benefit most from this drug?
So as the underlying the mechanism of action is like to take care of fibrosis very well. So in the lesions where you have the fibrosis is the main pathology, it works well. So the skin is the condition, especially the late skin changes which are causing fibrosis and contractures, the joint and the joint involvement, the fasciitis, the lung GVHD is a very it works very well. The GVHD of eyes. And the other thing is like liver GI, GI involvement, it doesn't work very well. In my experience, actually I have used in 2 patients for my patients. And for GI it doesn't work, for skin it work very well. Actually. So the fibrosis and sclerotic part is taken care of very well with this one.
And how quickly will we can see the response? How quickly will it work?
So the median time is around 1 month. The rest, it depends on what organ is involved, what symptom patient has. If there's just pruritus, it usually responds early by 2 weeks or so. But if it is lung or liver, chronic GVHD, it takes a longer time.
And what are the side effects, Dr. Nikhil?
It can be the nausea, vomiting, you can see. There can be rise in the transaminase levels, these can be reached, and there can be headache, the child can complain of weakness. Apart from that, there can be unexplained side effects.
Among these side effects, what do you think are the red flags for its use, which can lead to dose modification?
The unexplained side effects, and then there's a evaluation saying that this causing liver injury, and then persistent delivery process, GI.
Though the incidence is less, but it can cause significant GI toxicity and unexplained cytopenias, which can lead to dose modification and may lead to discontinuation also. Any role in acute GVHD? Very quickly wind up. Any role in acute GVHD?
As we discussed a lot about this anti-fibrotic action, so most of the time effective in chronic GVHD, but certainly some inflammatory markers get reduced with this drug and cell activity. So might have in acute GVHD, but no
solid data.
Yes, at present.
And can we combine it with other drugs like oxalitinib?
So yeah, the third degree makes a perfect sense because the 2 drugs act on different sides of the Jakavi action and initial cytokinin related part, and the bilirubin acts on the later part, which is associated fibrosis and immunomodulation. So yes, but there is no much of prospective data. In some small studies like MPKCC, you can see that they've used in it and they analyzed almost 50% response rate was there. So it looks very promising actually because of the synergism of the 2 drugs.
Means the drug itself is new and the combination is even the newest. There's another drug called exactly, which is a CSF1R inhibitor, which their studies are going on for its combination also. So that's it. I say thank you panelists, and thank you audience for patient listening of a boring pharmacological lecture. Thank you so much.
Thank you so much, Dr. Sunisha, and thanks to all the panelists, especially for hailing from Jaipur for this amazing discussion. Next in line, we have 2 very important lectures from hematology. The first I invite the chairperson, Dr. Mukul Agarwal. Sir is an associate professor in clinical hematology in AIIMS, New Delhi. And for years, sir has been a go-to person for calling every hemat response, every patient, every family member, and sir has been very, very responsive with his phone calls. So thank you so much, sir, for being that patient clinical hematologist for us. I invite Dr. Richa Jain. She's an associate professor in pediatric hematology, oncology, and PMT unit in PGI Chandigarh. and she has been awarded with the amazing topic of how NGS has changed my practice in managing benign hematological disorders in 2025.
Hi everyone, and thank you very much, Dr. Vikas and team for inviting me here. It's a pleasure to be here. So, I think traditionally how we diagnose patients was that how we were taught when we were doing our MBBS and MD, as well as being for that matter, that good history and examination. And I'm sorry, I don't know why the slide is not coming up properly. But good history and examination followed by very focused CDC pelvic smear assessment, followed by focused lab tests like a marrow, like a HPLC, like a direct Holmes test, etc. And you would achieve the diagnosis in majority of the cases. However, with this spectrum, 5 to 20% of the cases are difficult to diagnose. Where we traditionally, till we had access to genetics, we would typically wait and watch. Disease would progress, new symptoms would develop. You would reassess after a few months, repeat investigation. Sometimes you ended up doing bone marrow 2, 3, 4 times also for patients. And then the wait and watch continues. So over the last 2 decades, because of the progressive genomic diagnosis or availability of Sanger sequencing, karyotype, targeted panels for NGS, whole exome sequencing, and chromosomal microarrays, these 5 to 20% of the cases now start getting resolved. So where does NGS factor in benign hematological disorders? IBMFS is one very big spectrum, aplastic anemia-like presentation of patients where having a genomic diagnosis would really change the therapy significantly. Difficult to diagnose hemolytic anemias, bleeding disorders, and iron metabolism-related disorders, which I will just be talking about individually now. So let's just come to case scenarios. So I will just illustrate a case here. So this was a child who came to PGI, Master G, a 6-year-old boy resident of Punjab, and he had progressive pallor noted appearance since he was 1 year old. So there was no real significant history except for just pallor which was noted. There was a blood transfusion at 1.5 years of age when his HP was 7ish. And now he had come to us with 6 years of age. So our history was taking us more towards the iron deficiency anemia, but the child had been on oral matrix for the last 4 years. With no significant improvement, his HB used to hover between 7 to 8 grams per deciliter. The dietary history was non-representative, it was normal. And on examination, the significant finding was pallor, a normal anthropometry, no jaundice, and no organomegaly at all. So it was a non-syndromic anemia, likely an iron deficiency anemia on the face of it, or a mild hemoglobinopathy where we could not find this. So we did a CBC at our center. We found anemia, HB of 7.7, moderate to severe. RBC count was reasonable. Retic was on the lower side for his HB, and there was significant microcytosis hypochromia here. And platelets were elevated, suggestive of thrombocytosis secondary to iron deficiency anemia. So we gave him a trial of oral iron for 6 weeks. His renal liver function CRP was all normal. In 6 weeks of regular oral iron, his HB had only risen by 0.4 gram per deciliter. So we were looking at iron refractoriness here. So we ensured compliance, we ruled out other causes. When we see these patients, our differentials are microcytic hypochromic anemia of long-standing duration, iron deficiency, thalassemia, sideroblastic, or iron. So we did a stool operant which was negative, a Beckel scan which was normal, a TTG throughout celiac which was normal, and a HPLC which was essentially normal. And iron profile done was very consistent with the diagnosis of iron deficiency anemia, and this led us away from a diagnosis of sideroblastic anemia where a TSAT and ferritin would be a bit high. So here we proceeded with evaluation for IRIDA. We have an in-house NGS panel with about 26 genes for all iron metabolism related disorders. And with that, we found a pathogenic confound heterozygous mutation in TMPRSS gene, and that both the parents were heterozygous for that mutation. So this child received parenteral iron, and his HP, you can see how remarkably it improved from 7 grams, it shot up to 14 grams. He persisted to have some mild microcytosis, which is a hallmark feature of IRIDA, that even after improvement in HP, the microcytosis remains. However, the child is doing quite well otherwise. and he continues to get intermittent once in every few months he requires iron. So that is the therapy he's on. So I will just bypass this and just talk about the role of NGS in inherited iron-related disorders. It helps identify IRIDA, which is a genetic diagnosis primarily. It helps us identify sideroblastic anemia, especially in children who have a bone marrow which is not 100% clear for sideroblastosis. Other rare iron metabolism disorders like atransferenemia, DTM1 mutation, which are very rare cases, difficult to diagnose, but finally there are those 1 in 100 cases which you would see in a difficult busy clinic, where only NGS will help us make a diagnosis. And it helps in treatment decisions and prognosis, especially if we get a genomic diagnosis for the sideroblastic anemia types. I'll come to another different spectrum of case. This was a very intriguing case and very difficult for us. This was a 9-month-old girl who presented with spontaneous onset of bleeds from the age of 6 months onward, and she had a bleeding score which was higher than was expected for her age. There was no history of bleeding in the family. We did a coagulogram and the APTT was significantly prolonged. So she was a girl, 9-month-old girl with a significantly prolonged APTT. Is it a von Willebrand? Is it a factor XI deficiency? Or is she a carrier of hemophilia A or B with a severe manifestation? So mixing studies and factor VIII assay both were taking us towards a factor VIII deficiency and hemophilia. So causes of low factor VIII in female, usually a symptomatic severe female carrier can be there, von Willebrand normandy or a type 2 in von Willebrand disease or female hemophilia A. So the parents were phenotypically normal here. We were assuming that the mother may be a carrier and the father may be a mild hemophilia here. And we proceeded with genetics here. First, the coagulation screen for the parents, where both the parents had good factor VIII levels. So that kind of took us away from father being a carrier. And then we did a mutation analysis where we found that in the targeted next generation sequencing, we found a homozygous missense variation in exon 4 of the factor VIII gene, which was confirmed by Sanger sequencing. Again, I don't know why the graphs for Sanger are not showing up here, but there were nice Sanger graphs over here, where the index case was showing up as exon 4 homozygous deficiency, though the mother and the father both came out to be normal. So, why is a homozygous, de novo homozygous mutations are so rare with normal parents, so we were like flummoxed why she is having this kind of a presentation. Our possibilities were sex chromosome aneuploidy, antigen insensitivity in an XY child, misexecuted paternity, or localized chromosomal structural abnormalities. So we did a PCR amplification test to rule out antigen insensitivity. A karyotype was done to rule out Turner syndrome, and a VLTR analysis was done for paternity testing, all of which were normal. So we were left with localized chromosomal structural abnormalities, at which time we did a chromosomal microarray. And what we found was very interesting. What we found was that the child and the mother, child was actually pseudo-homozygous with mother having a deletion in the X chromosome which involves the factor VIII gene. So the child that was not picked up on the Sanger because it was a large chromosomal deletion, and the child had done de novo mutation. So she got a chromosome X deletion with the factor VIII gene disappeared from one mother, and from the father side it was a normal chromosome X which got hit by a de novo mutation. So that is what we were looking at. That again, some issue with the slides, but this was the index who has one deleted X chromosome inherited from the mother, the factor VIII gene missing, and from the father side it was a normal X chromosome, but there was a de novo missense mutation. So this child is on our regular follow-up. She keeps on coming for intermittent factor requirement with some bleeds. Fortunately, she hasn't had a major bleed as of now. So, role of NGS in bleeding disorders, this is one difficult case where we could establish a diagnosis only because of the genomics that we undertook in this child. However, it's essential in chronic ITP, especially before we are planning something definitive like hysterectomy, because 15 to 50% of the patients with chronic ITP now are seen to have other disorders like inherited thrombocytopenia syndromes, primary immunodeficiencies, and immune regulatory disorders. And there are other difficult to diagnose platelet function disorders like great platelet syndrome, maybe MYH9 related abnormalities, alpha granulin defects, and external thrombocytopenia, or other rare coagulation defects which would use NGS for a definitive diagnosis. So there are a lot of chronic ITP mimickers which are only diagnosed with the help of genomics, which include platelet production disorders, platelet destruction disorders, like function disorders, which may be picked up otherwise also, but at times we have a difficulty which are finally being picked up by NGS. Primary immunodeficiencies like WAS and CVID, which may present with only thrombocytopenia, immune dysregulation disorders which would need definitive therapy, and autoimmune disorders which again would need definitive therapy. So misdiagnosing these can lead to inappropriate immunosuppression, splenectomy, missed opportunities for targeted therapies, and lack of proper genetic and family transfer. So this is another very interesting case. It was a 12-year-old boy, resident of Bihar, who came all the way to PGI for establishing the diagnosis. His problem was that there was an incidentally detected splenomegaly which was 6 centimeters below postal margin with no positive history apart from that. Anthropometry was normal, he had no mild pallor and other organs were normal. So this was the CBC he had, where we can see that his HP is mildly low with more or less normal indices and a platelet which is borderline low. So he underwent extensive evaluation in Bihar and UP in Delhi over 6 months to rule out infections, portal hypertension, chronic liver disease, marrow-infiltrative disorders. He had a normal HPLC and a bone marrow was done at 2 big institutes twice under pediatric hematology oncology services and only showed mild erythroid hyperplasia and nothing else which was significant. A possibility of Gaucher disease was considered and a big beta glucoside enzyme assay was done, which was persistently low at 2 different centers in the whole blood. NGS was done for storage disorder, it was negative. Sanger sequencing was done for the GBA gene and it was no pathogenic variant. So the patient's family got very exhausted. They were a low middle class family when they came to us to establish a diagnosis. So in looking at the CBC, the first thing that we asked for was a peripheral smear evaluation and a family screening. So the family screening showed that elder sibling, who was 16 years old boy, had a HP which was also low, had a platelet which was low. This was done in Bihar and Send, and eventually when we examined this elder sibling, he also had a 5 centimeters splenomegaly below the costal margin, but was totally well. Father had a mildly low platelet count and mom had mild anemia. So a peripheral smear evaluation was done by an experienced pathologist and we found stomatocytosis and many large and giant platelets and a mutation which was positive for Mediterranean stomatocytosis or cytosterolemia. So I don't see why I'm not able to display all the pictures. It was a very nice slides. The pictures are not coming up actually. You can see stomatocytes very beautifully in this. So I don't know why all the graphs of genomics and the peripheral smear pictures are missing here. So stomatocytes are very easy to misdiagnose as basically as artifacts. So आपको format है कुछ और ये सारे ग्राफ स्लाइड्स में पिक्चर्स में नहीं है विंडोज पे nice stomatocytes anyway. So another childhood stomatocytosis, again you can see the pictures are all missing here, but nice stomatocytes, a family of hereditary stomatocytosis where it was incubated OFT was positive in the index case, but the peripheral smear showed stomatocytosis. So these children were all started on ezetimibe, which is an oral cholesterol absorption inhibitor, and echocardiography, ECG and carotid Dopplers have been done. They have advised diet doing plant steroids. Ultrasound for fatty liver evaluation has been done because they behave like hypercholesterolemic disorders, and we are following these children up regularly. They are doing well. So these are the mutations involved with the stomatocytosis and thrombocytopenia, ABCG5 and ABCG8 mutations. And a lot of these difficult hemolytic anemias are finally diagnosed. Again, the slides are missing, but finally diagnosed because of NGS from our end. So there were a couple of slides of overhydrated stomatocytosis and xerocytosis, but and the therapeutic implication in those patients is that we cannot splenectomize them as they have a procoagulant state and they would have thromboembolism. So again, it's very important in IBMFS, which everybody knows. So genomics is essential before we give either immunosuppressive therapy or plaque transplant. So this was a 16-year-old boy with a very nice CT scan again, which is MIA. And he was a transfusion-dependent anemia onset at 2 months, followed by pancytopenia at 11 months. Had an absent left kidney. There was some response to steroid, but he remained to be transfusion-dependent. Had chronic diarrhea with increased fecal fat and fatty infiltration of pancreas, and the common is a Schwammer-Diamond syndrome on the clinical phenotype. However, the gene sequencing showed no variants. NGS with 86 gene panel for IBMFS was done in-house, which showed a mutation in the RPS19 gene, which is a classic DBA phenotype. So he was finally a diamond-blackfan anemia with pancreatic liponephrosis. And similarly, a child, a 9-year-old boy, who presented with transfusion requirements for the last 4 months with no past history, no significant physical abnormalities. CBC showed pancytopenia, bone marrow was hypocellular, so this was aplastic anemia, and a chromosomal breakage study was normal. He did not have a second heart for PFT. So we were again flummoxed here. We gave immunosuppressive therapy because we didn't have anything else to do, but he had no response to it. A chest X-ray, which was done during a febrile episode, was shown to have rib anomalies and vertebral anomalies, and a genomics done in-house finally showed us Schwammer-Diamond syndrome in this particular child. So NGS and aplastic anemia is essential to rule out bone marrow failure disorders. Prognostication and appropriate therapy can only be done once we have a genetic diagnosis. IST would not be useful and would harm a lot of these children. And decision to do a transplant, the conditioning, the donor use can only be decided once we have a definitive diagnosis. Long-term follow-up plans can only be decided with a genetic diagnosis. However, they need to be used with caution with appropriate pre-test counseling and post-test counseling. We need to remember that counseling for a single gene disorder and an NGS is different from a whole exome sequencing, where we can get a lot of variants which are unrelated to the primary condition that we are treating. And the parents need to be aware of that, because it would increase stress if we are give them a PUS and some vague disorder which the child does not even have. The family needs to be told that there is implication of those genetic diagnosis, because one of the parents may be a carrier and would need further evaluation. So we need to have clarity in the clinical indication and NGS whole exome sequencing, which is we are doing outside of research. And pre-test, we must know what to expect so that we can do that counseling. Just because parents keep on saying kuch to karo, parental anxiety is not an excuse. Logical reasoning and counseling is required. I'll end here. Thank you very much.
Thank you, Dr. Rekha.
Yeah. So after this very lucid talk, I think we have come to the last talk for the day, which is going to be given by Dr. Vaneet Anand. He is a consultant pediatric hemato-oncologist at Rotary Ambala Cancer and General Hospital Ambala, and he will be speaking on pediatric idiopathic aplastic anemia.
So very good afternoon. Before thanking Dr. Vikas and team, I would like to thank the few people who are sitting here, and thanks sir for changing the session at that last time. So I'll be very quick. So my topic is treatment of idiopathic aplastic anemia. So we would be covering for the fellows a bit on the diagnostic workup, treatment strategy, the IST versus transplant, the different type of transplant and how we are moving from MSD to now people doing haplos, role of L-thrombopac, and some practical Indian algorithm. So, as ma'am already said, Dr. lecture about bone marrow, the IBMFS, the inherited one and acquired. I will be covering only the acquired one because inherited needs another detailed talk regarding the NGS. Of course, ma'am has already told, and the treatment aspect is also different. So we all know about this severity on the Kamita criteria for the fellows, if present, I don't know. Severe aplastic anemia is when bone marrow cellularity is less than 25% with 2 by 3 of the following parameters: neutrophil count less than 500, platelet less than 25,000 or 20,000, and a retic count, again the absolute retic count less than 20,000. The ANC less than 200 is, we all know, an emergency and would be very severe aplastic. So investigations, we all are aware, we need a good CBC with the peripheral smear. The low retic count would again point towards aplastic, and the child would need bone marrow aspiration with biopsy. Biopsy is a must here for diagnosis, And cytogenetics and fish abnormalities can be found out, and fish for monosomy 7 or 5q deletion to rule out NBS or malignancy is also done. We need to rule out other causes of pancytopenia, LFT, it's non-A, non-B, non-C hepatitis, but of course hepatitis would be present. Viral studies, the EBV, the parvovirus, vitamin B12 and folate levels, autoantibody screening if you suspect SLE, then this chromosomal breakage analysis is a must for ruling out Santonese. NGS has already been discussed. PNH needs to be ruled out by flow, and centers are doing it annually. And HLA typing is a must once the patient comes to you, because now the line of treatment is moving towards transplant. So this is a summary of the extensive tests which all need to be done whenever we have a case of aplastic. So this is the rough treatment guidelines. People may vary, institutional preference is there. So once we have a diagnosis of severe aplastic, the HLA is must. If MSD, matched sibling donor, is available, that's the first line of treatment. If not, we can move towards IST, or some centers are doing MUD or haplos. So in ITG, we have rabbit or horse or the bone marrow transplant. So coming to the first line modality first, the matched sibling donor is the preferred one once the MSD is available. Pediatric studies are showing overall survival of 90 to 95%, low chronic GVHD and excellent long-term outcomes. So I put this study from the host institute only, that's the Fortis data, Vikas is the part. So which shows once MSD was done, the 2-year overall survival for the entire cohort was around 93%, very low acute GVHD and almost zero chronic GVHD was found. This was the EBMT data by Dufour et al., which again showed there was a comparison between IST and I'm not able to see my notes. Okay, IST and the transplant data, which again showed that the event-free survival was around 85-26% in patients undergoing MSD, while it was only 37% in children who received immunosuppressive therapy. Moving to the second line, MUD, which outcomes have improved of late with good conditioning regimens and infection controls. Overall rates OS of 75 to 85% have been observed, but of course the limitations being donor availability, cost and time to transplant, because aplastic would be an emergency, it would not be like a benign condition and we need to move fast. Late referrals or late transplants would of course be dangerous. And as I already said, the roles are individualized. A lot of centers now prefer doing MUD or haplo rather than IST, which would depend on the center expertise and of course infection control. This was again, I could not find any studies between MUD and MSD upfront Indian studies. So this was an EBMT study which compared upfront MUD and MSD, and outcomes for both were similar in MSD transplant, and they were of course superior to immunosuppressive therapy. So the problem lies this paper I put, because only a quarter of the patients would be able to find a MUD donor. So that's the main thing, and waiting and time period, late referral is of course something which is dangerous for transplant patients. Moving to haplo donors are of course available for more than 90% of the children. The ETCY has of course made haplo very much feasible in this line, but the infection control and is the major thing which needs to be seen. There are reports showing OS of 70 to 90% with acceptable GVHD and graft failures. Again, the last point requires experienced transplant program and of course intensive supportive care. So this was a consortium, Pediatrics SAA Consortium of India by Khare et al., which of course again shows the haplo data from Indian scenario, and they have shown that haplo had improved results in high risk, heavily transfused or IST failure patients, and early referral is something, and infection control which needs to be seen. There are a lot of more studies which I couldn't really find much data on, which are ongoing showing success of haplo transplants in India. Challenges faced by them again, graft failure and infection control.
Coming to the second line, if MSD not available, the IST immunosuppressive therapy, we all know horse ATG plus cyclosporin is the standard immunosuppressive therapy. Response rates, the CR is 10 to 20% in most of the cohorts. Horse ATG is superior to rapid ATG for initial immunosuppressive therapy, and it remains line in children without suitable donors. And of course, in India, a lot of economic constraints where transplant is not feasible. So this was Shindek et al. The horse ATG versus rabbit ATG trial where HATG was superior, and 68% versus 37%, and 3-year survival was clinically significant, 96 to 76%. This was a meta-analysis by Hayakawa et al., which showed higher early mortality in the rabbit ATG group. So horse ATG is of course preferred over rabbit ATG. Coming to the response criteria, so CR is something which is appropriate for age, ANC more than 1500 and platelet count more than 1 lakh. PR would be non-CR, HP more than 8, ANC more than 500 and platelet less than 30,000. So there's a lot about the use of L-thrombopag in adult studies. They're saying, so the studies have shown that in adults, L-thrombopag added to IST has been useful. But the pediatric studies, so this was the data by Townsley et al., which showed it is very useful. But in systematic reviews and this Gloarke paper, in pediatric studies, it's something which needs to be proven. They say early addition of L-thrombopag to IST has shown response, but we need more prospective data on that in view of the clonal evolution. So practically, I guess a lot of practitioners are adding L-thrombopag to IST first line. GCSF has as such no role and is a risk factor for MDS or AML progression. Any aplastic would of course need a lot of supportive treatment in terms of restricted transfusional policy, prompt management of infections, which is febrile neutropenia, which is the main thing we need to manage whenever an AST comes to us. Finally, coming to the last slide, early diagnosis and early referral are very critical. So transplant referrals are something which needs to be done. If the MSD is available, it's the first line with good overall survival. If the MSD is not available, IST as per the guidelines is the mainstay. And thrombopag has shown to improve response when added. Haplo is feasible, but outcome will depend on the center expertise and infection control. We should avoid, of course, as already said, over the transfusion in these patients because of the risk of alloimmunization, and good infection control is something which would help. So the right treatment and right timing would determine the survival in these severe aplastic patients. Thank you.
Thank you. Just one question, why do you think this L-thrombopag not working?
So maybe the age as I read, because it has been given for long and we need more prospective studies to look for the clonal evolution. That's what I would really, and in adults that's something which would.
Any questions?
And if maybe sir you can help us with that. Why is it like, what is the reason? Because adult trials have shown a lot of response to L-thrombo, I think all are doing, but pediatrics may.
The initial study in adults that showed almost 90% response, but the X3 study from Europe that has shown more subdued response, somewhere around 70-75% as compared. It helps, L-thrombopag helps in adults. There's a lot of data that it helps in children too. So,
refractory, it's more in the relapsed refractory patients rather than naive patients.
So we at our center we are adding for all the.
So most of the people, I think, ma'am.
Any great action. So we have stopped doing that. In the last refractory, yes. When transplant is not an option, then cyclosporin, restarting cyclosporin along with L-thrombopag helps. There are some children who are on limited cyclosporin and more of L-thrombopag. They are used to that. One reason would be in pediatrics, maybe that we are missing a subset of patients who have tailor shortening or other problems which are not very easy to pick up even with NGS or collates. But overall, the responses will nothing close to what the published health literature has been.
So, the phase 3 trial that from Europe, the RAISE trial that has come down to from 90% that has come down to 70-75%. So that is what we are getting around 60-65% response in overall population. That's a good response.
Vikas sir, are you using?
Sorry, I didn't get the question.
Sir, the use of eltrombopag, maybe in de novo or relapsed refractory.
Eltromo with aplastic.
Pediatrics.
With ATG.
Without.
Oh yes, so we are using eltrombopag in each and every patient who comes to us for ATG based therapy. Our results are pretty good. What I have seen in the last couple of years with the addition of eltrombopag and by keeping the cyclosporin level between 200 to 400, not 150 to 200, we are seeing responses in more than 90% patient, and that is happening between 1 and 3 months. Between first to third month we see responses.
That is a bonus. What is the way we have bonus?
No, we haven't done that.
Because we have responded to this upfront
Doctor, do you keep your cyclosporin levels a bit on a higher side or do you keep
above 200? So in fact,
probably what has been kind of
literature so some published literature 90% sounds like wonderful.
Yeah.
We would be like through the roof if we were getting 90% of the response rates are much lower. I think the only other center which has reported actually written reports of this outcome is the army.
I'm talking about CRs and PRs. I'm not talking about CRs.
Any response we see maybe 50 to 60%.
So in a transplant fusion, there was a time when I was thinking whether I should do a haplo or a transplant because
Transplant could be a patient.
probably God has been kind of focused. Thank you.
So that's a very wonderful outcome.
There are no further questions. Thank you, organizers.
Thank you.
Thank you, Dr. Rajeev sir, and thank you, Dr. Mukul sir. That was the insightful discussion on aplastic anemia. So, thank you, audience, for coming to the first inaugural meeting of HEMENEXT. We look forward to continue to enhance the knowledge and empower us with further HEMENEXT sessions, maybe next year. So, the lunch is now open, and I request everybody to please have lunch. Thank you.
response, which is going to the response need to kind of break me. It's different
खाली हो ना अभी खाली हो ये पैकअप करना है भाई यहाँ लाके लैपटॉप दे दो कार्ड कॉपी कराओ मेरे पास कार्ड कॉपी करने का टाइम नहीं है अच्छा तुम जाओ बात करते हैं फ्री में जब तक कार्ड कॉपी करने का टाइम
एक और चीज करनी आपकी को मैं नेहा को बुला देती हूँ नहीं आप इट्स पॉसिबल वीडियो ऑन हो सकती है साइड में आगे वाले सभी अच्छा कोई मुझे बात नहीं राजस्थान में किसी को खबर दे रहा है बैग सही है सबकी उसमें नहीं लिखा मेरे में लिखा होता है इसके लगे लिखा होता ऐसे तो अच्छा नहीं लगेगा ना खोल के देखो
स्पेशल है क्या बैग? स्पेशल
चलो बाय मैम you take care
So, nice meeting you. Really? Yes. Don't happen so much. Very nice to meet you. Sir,
क्योंकि डिस्प्लेशियाज आ रहे हैं। अब देखो मैं अनुमान लगा रहा हूँ, आई एम नॉट वो ऐसे बोलते कि कल जा नहीं पाया था, लेट हो गया था आउटसाइड के लिए, तो अब साइबरनेटिक्स किस चीज़ के लिए भेजना है ये भी पूछ रहे थे। ठीक है ना? हाँ ओके। How it was. I just शायद हो गया होगा। नहीं बिल्कुल नहीं, थैंक गॉड।
कंसोल पे मत उतारा करो भाई, कैश लिया था स्मेल आएगी तो बोलेगा। उसने दिखाई थी सीसीटीवी, पता नहीं ध्यान कट रहा है। उसको बोलते ना ड्रॉप पर डे, आपने टीम बोल दिया मैं उसको सब बता दिया, मैंने बता दिया इसको नहीं करना। बाकी के तेरे पास मेरी गाड़ी का वो भी दे मेरे पास मैं गाड़ी लेने गया था, बैकग्राउंड दीजिए बाजू मैंने कहा ये कौन सी गाड़ी है। यहाँ तो तीन होगा उस वाले हॉल का करेंगे। Yes, sir.